on, so I think she'll plan to do the intro remarks. So of course, whatever you want to put in the chat or add anything in, always welcome.
Jack, it's just letting you know I'm downloading it as we speak.
Okay, sounds good. And yeah, I think it seems like, Claudia's got this slide up. I think everyone else is prepared to share their own. So I think that'll just be our insurance policy. Claudia, I will stop talking and go off camera, and feel free to just give Lloyd the thumbs up whenever you want to get started.
Will we know when, will I know when to go ahead? Can I just launch in, as soon as you do that, or?
So I think, so it's currently recording now, and I think whenever you say to go live is good. We have 20 attendees right now.
Okay.
Quick question. Do you have all your presenters?
We have first up is gonna be Kathleen or Rob, and then John and I will do just a few minute intro, and then I believe Joletta will go first, then Dave, and then we have both of them, and Katie and Meryl, I think I saw in here. Yep. All right, so we have our first presenters lined up and ready. So I think we should be all set. Fanan and Renee are going next. I think we look pretty good. Okay, everybody ready? Yeah? Super. Okay, I'm getting the thumbs up. Let's go live. All right, welcome. Thank you all for coming and attending this. I'm Claudia Campbell. I will be co-chairing the subcommittee meeting. John Farrar, our chair, will be joining momentarily. We just wanted to give a quick welcome. We have a packed agenda, and so we'll be turning this right over to Kathleen and Rob to give some overview and introductory remarks. Thanks.
We're not hearing you, Kathleen.
What?
Now we can hear you.
All right, you can hear me? All right, good.
Yeah.
All right. Something with the speakers again. And then we just tested it. All right. Let me try and share the screen again. Okay. Let's go to here. Are you seeing my slides now?
Yep.
All right, great. Better than the last time. So welcome everybody, and we're really excited that you're here. I'm Kathleen Sluka, and I'm here with Rob Giroux, and we are the co-chairs of the HEAL Pain Strategic Planning Executive Committee. And we're here to look to for a workshop of the optimization of interventions to improve pain management group. And there, as you're going to see today. So I wanted to give a little introduction first about what the HEAL initiative is. This is Helping to End Addiction Long-Term Initiative. The HEAL initiative is an NIH-wide effort to really speed scientific discovery and solutions for the opioid epidemic, which includes the crisis of chronic pain, which is a bit of how we got to the opioid epidemic. It launched in 2018, so we're 5-6 years or more into this, and they've funded over $3 billion in research so far in every state, so nobody has been left out. It is a collaboration across multiple institutes and centers, and it is very encompassing across many different things. I think it's important to keep in mind what the mission statement is as we think through what we're looking for here. The Heal Pain Research Initiative aims to reduce pain and the risk of opioid use disorder by developing safe and effective pain treatment and prevention strategies to improve the quality of life for all people. So that has a lot of aspects, as you'll see. We have many working groups to work on this. Many of those initial projects are just wrapping up. Many of them were funded in the first few years, and so we're starting to see some fruits of all of the hard work that our community has done. And what we're looking for now is input from the broader research community to help us form research priorities that will set the pain strategic plan for the next 5 years. So this is a picture of the executive committee. Again, Rob and I are co-chairs. We have Michael Falcon, who is a person with lived experience that also sits on the executive committee. And then we have taken the initiative and divided into 7 subgroups, as you see here below. As I said, today you're in the optimization of interventions to improve pain workshop, but we have 6 other working groups, a couple of which have already had workshops, and as you'll see, several are still upcoming that you're welcome to attend. In fact, here's the workshops, and you catch this QR code. You can go there to register. You see we are on the optimization one. We still have 3 more workshops we'd love to get your input on if you have an interest in that and would like to join us. So in the summer, we asked for a request for information from the public and the research community and we've used all of that to kind of help form these subcommittees and priorities of each of these subcommittees. We're now in the process of getting input from the community through these workshops, and there's also a request for information where you can see this email at the bottom where you can send any thoughts you have that you didn't get raised in these workshops. And we're looking at all this information and we're putting it together, and our experts are reading through this to try and figure out where to go next. In January, we're going to have a meeting to kind of refine all and prioritize all of these research strategies across all the subcommittees. And eventually we'll take this to the National Institutes of Neurological Disorders and Stroke, or NINDS Advisory Council, for approval and suggestions. And then NIH will start to develop and publish the strategic plan and then implement it after that, with the hope of implementing this plan in 2027 and beyond. So again, if you have comments, please send them to us. We look at all of them, we read them, we summarize them, we kind of look for similarities, we look for everything that's out there, and we're really looking for input from the community. You are here to participate in this workshop. The last thing I will say is please feel free to use the chat. Many of us will be in the chat paying attention. If you have questions, we have ample time for discussion in this workshop. Please put them in the question and answer, and we will get to them and we will have discussion within them. So again, we're looking for an active discussion and an active interaction as you go through. And thank you. I look forward to listening.
All right, thanks so much, Kathleen. So I think as we wait for John to join us, I'll just go ahead and start with some brief introductory slides ahead of our scientific talks. So let's see. Oh, can everybody see this?
Yes, but you probably should put them in presenter mode. There you go.
Perfect. Okay, great. Thank you. All right. So as Kathleen mentioned, you were at the optimization work group talk. And we wanted to start off just defining optimization. So if you go to Wikipedia, it says an act, process, or methodology of making something, such as a design, system, or decision, as fully perfect, functional, or effective as possible. It was actually a little bit tricky to find pain-specific optimization definitions. Some of the other work groups have had papers and other things that they were able to reference sort of specific on mechanisms or other, very specific areas. Ours is pretty wide reaching. So optimization intends to ensure that the right patient gets the right treatment at the right time, which we thought was very applicable to this. It's actually pulled from the pharmacy literature. And from the HIV literature, we have another, I think, appropriate optimization definition here, but that we are looking to deliver the best possible treatment or combinations of treatment to affected populations. The value of recommended interventions is judged by their long-term efficacy, safety, tolerability, adherence, and convenience. So really covers a wide area. All right, so our methods for generating these priority topics included bringing together this terrific group of people, which we'll introduce in a moment, some initial brainstorming and generating of topic ideas. So everyone was asked to come up with what they thought were the most important areas within our optimization topic. So optimal modes of pain management were discussed, multimodal approaches, key components of effective treatments, individualized treatments, of course, resiliency, resolution, prevention of chronification, the acute to chronic pain transition. So common themes were merged together once people submitted their ideas. We attempted to synthesize them into subtopic groups. And then the members of our subcommittee voted on which subtopics they were most interested in and passionate about. They worked together to refine the priority statements and generate the slides that you're about to see. We also established a parking lot for relevant topics with less enthusiasm or that weren't as highly rated. And also ones that might be handled by other groups. As you all know, there are a number of groups that Kathleen went over. So some of them are very relevant to optimization, but might be handled elsewhere. All right, so we wanted to acknowledge that. All right, so walking into our optimization subcommittee, we have a dream team here, and our first is the Enhancing Care Delivery Strategies subtopic group with Meryl, Katie, and Dave. Our next group that will talk is the Personalized Pain Management Priorities group, and that is Fanan Rasu, Renee Manwaran, and Asaf Bari and Joletta. We're really delighted and fortunate to be able to have patients with lived experience on each of our subcommittees. So we'll be starting with their talks, but we're really excited that we were able to ask them to pull double and even sometimes triple duty to be on and have representation on each of our subtopics. So prevention across the lifespan, Jennifer Rabbits, John Farrar, and Joletta. And then treatment combinations, we'll have Jennifer Gawantner, Ben Alter, Dave White. And finally, our cross-cutting values group that is including Adam Hirsch, Jeff Dusek, and Joletta again. And their group covers topics that sort of cut across each of our other subtopics. All right, so a little bit of housekeeping. You'll notice in the bottom of your screen, there is a chat function. We really want to encourage active participation and lots of discussion. So please use the chat function and we will either respond to comments in chat or include them in discussion. You also have a Q&A function. You can use that to ask questions, and we will respond either there or live here. All right, so our agenda, we already heard Kathleen and Rob give some introductory remarks. This takes us through, oh, you're right on time. This takes us through our brief overview and agenda. First, we'll hear Joletta and Dave talk about their experiences, and then we'll move on to our scientific presentations. So the intention is to have about 10 minutes of presentation with just a couple of minutes of specific Q&A for the specific, like if there's any clarifying questions or that kind of thing associated with any of the talks. We'll have a break and then have our last two subtopic groups present their materials. And then we have plenty of time for discussion of the presentations and panel discussion of the priority areas. And then we will hope to synthesize and put everything together in next steps and adjourn. So with that, I will turn it over to Joletta, who will speak next. Joletta, did you want to share your own slides here?
Yes, if I could, that would be great.
Perfect, absolutely. Thank you so much.
Get this going. Can you all see that?
Yes, perfect.
I'm sure someone will tell me if things aren't working well.
Looks
We
good.
Thanks
see.
thanks so much
Looks
for
good.
the intro. Awesome, thank you. And thanks so much for the introduction, Claudia, and thanks to the entire team for this opportunity to ground today's workshop in lived experience with Dave and I kicking things off. I'm going to share some of my story of pain and treatment, but it's just a glimpse into years, decades of experiences, interactions, treatments, and reflections. And it's just that one person's story amongst millions of stories of pain and perseverance. So to start, I became a firefighter in my 20s. Here's me on my big first structure fire, my first big wildland fire, and also leading a bunch of teenagers, fire explorers, into a refinery fire training drill. I absolutely loved my job. And if you'd asked me to describe myself, I would have answered, I'm a firefighter. And to me, that encapsulated all that I was. I was also a paramedic and a peer fitness trainer. To totally brag, I was jacked back then, leading morning physical training for our fire academy recruits and designing and delivering workout programs for our firefighters and civilian staff. Then one day I stepped off the fire engine as I had thousands of times before, but this time I missed the step and I felt a twinge in my hip. It was just a twinge, no big deal. I still worked as a firefighter medic for another 5 months, but that misstep, that twinge, set me on a path of ongoing worsening pain that did not respond to treatment, did not get better like it should have, and turned my life, my world, and myself upside down. That very specific pain in my hip, in the words of Drew Letter, diffused like a malignant mist throughout my experienced world. That misstep, that specific pain, led to the darkest years of my life. Years I was still working in a civilian position, although I don't remember much. Everything is obscured by that malignant mist. But I do remember this, going to yet another appointment in yet another clinic and standing at the counter filling out endless forms yet again, when the receptionist looked into the treatment area and said that the 2 o'clock hip was here. This image, created by my friend Sula Montalanos, she's in Australia, reflects how I was seen during those dark years. Just a hip. It's even more apt because for part of that time, my leg did not feel like my own. Of course, I knew it was mine, but it didn't feel like mine. And I'm very grateful to Oliver Sacks for writing A Leg to Stand On, or else I would have felt very alone and crazy in that experience. During those dark years, I saw countless doctors and health professionals, underwent a lot of treatments and therapies. Everything here that starred, I did outside of the health system, paying out of pocket because I was so desperate to get better, I would try anything. Everyone had a different diagnosis and plan to fix me, all of which I had the highest hopes for, all of which crashed into despair when yet another thing didn't work. It was a confusing time too, as many of the diagnoses and proposed treatments were contradictory, both within and across professions. until I reached the point that I was told there is no more that can be done, and I was on my own to figure it out. Now, usually when I tell my pain story, that's where I end. Then I talk about what I did and how I got better, not pain-free, but better, and what went wrong and potential solutions. But today I want to talk about what came before this chronic hip pain too. I grew up in a blue-collar family in Metro Detroit, born to teenage parents. That's my mom and me at age 7 and my brother. I was an athlete from the time I could walk. Don't let the genes fool you. Until I was hit by a car, driven by a senior, my junior year of high school the night before Powder Puff. It was pretty dramatic. I long thought that my hip pain became chronic pain because of those threats to my identity, that no longer being a firefighter, no longer being an athlete. Until last week, I pulled out this old paper in a scrapbook that my mom had made for me about my comeback after getting hit by that car. And in it, I talk about how with that giant plaster cast, I couldn't fit into my friends' cars. I couldn't do anything, and how depressing it was. How I had been a basketball player, a volleyball player, a softball pitcher, and that I had lost my identity. Yet back then, as soon as my cast was off, I was back to playing sports. No ongoing pain issues ever. During those years, I also had 4 broken noses, for which I had to have 2 reconstructive surgeries. 2 were from softballs, 1 was an elbow in basketball, and 1 was an unfortunate dancing incident. And I also had my wisdom teeth pulled. So that's 4 surgeries under anesthesia in my teens and very early 20s with no pain problems at all. I once played an entire softball game with a broken nose. It's that Detroit versus everybody blue collar upbringing in action. And oftentimes when I talk about after my chronic pain, I've talked about how I went back to grad school in human movement to better understand my pain and what I could do about it, which is not a viable, nor desirable, nor affordable treatment path for anybody. Being an adaptive snowboard coach for athletes with disabilities and having to unlearn much of what I learned in grad school, and how I try to make sense of things through writing. I talk about my advocacy work to integrate lived experience into the work of pain and the research partnerships I'm a part of, my patient and public partnerships editorial role at JOSPT, and cool initiatives I've been involved in, like Entrust PE and PXP. But I've never talked about my other pain problems or pain issues. Years after my hip pain, I had severe pelvic pain, which turned out to be adenomyosis, which I always say wrong, and fibroids, the largest bigger than a grapefruit, and was sitting up against my bladder, for which I had a hysterectomy. And yet again, no pain problems. And just this year, I was diagnosed with breast cancer, which came with yet another surgery, again, with no ongoing pain problems. I was the same person for all these surgeries, not to mention countless other sprains, strains, muscle tears, illnesses, and traumas. The same hypervigilant catastrophizer, yet pain only became chronic for my hip, not for anything before, not for anything since. There's a bit of a caveat there, as I'd actually had pelvic pain since I was 13, but it was never called chronic pain, and I never had a diagnosis other than it sucks to be a girl, until they could see a grapefruit where it shouldn't be. So it wasn't duration of pain prior to surgery that led to my hip pain becoming chronic. And with my breast cancer experience, while my care team has been wonderful, there are other challenges, the biggest of which is not having any oncology services in my county, none. So I have to travel a minimum of 3 hours round trip to every appointment, or, as is the case currently, get a hotel for daily radiation. I'm speaking from that hotel now. So it's a bit disruptive, and I'm incredibly privileged that I can stay in a hotel for treatment. Also, until I met my out-of-pocket maximum, which was a lot, the first person I saw for all of those appointments I traveled so far for was the person who wanted me to pay upfront for services. That's stressful, you know? It sets a tone that you don't matter. Your ability to pay does. So it wasn't solely the adversarial nature of the work comp system that led to my hip pain becoming chronic either. The health system has its own threats, challenges, stresses, and barriers, no matter how wonderful your care providers are. So what is it then? What is it that made that hip pain chronic and none of these other things? Is it stigma? Is it distrust of patients with pains that don't fit neatly into biomedical boxes? Pain not being believed in the same way as a broken nose or a fractured leg or a cancer diagnosis? I don't know. I'd love to find out, and I hope research can figure it out one day. So why am I telling you all of this? Because I think that living with pain and pain treatment is an important way of knowing pain that can help us as we think about what optimal pain care can look like and what research needs to be done to get there. This is my story alone, yet I'm not alone in many of my experiences. And sometimes we find the universal in the specific. Many people have had injuries and illnesses and surgeries without pain problems. Then suddenly they have a pain that becomes chronic. Many people are in adversarial or confusing or stressful work comp or health insurance situations. Many people face barriers to care, such as finances, access, acceptability, transportation, travel, needing time off, family responsibilities, bias, discrimination, disbelief, and stigma, atop all their other experiences, expenses, time commitments, responsibilities, and struggles. I'm telling this story because optimizing pain management for folks can mean a lot of different things and look like a lot of different things. There's no one size fits all approach to pain, even for the same individual across time, as my story shows. The only way we can improve pain management is through learning from, with, and alongside a diverse group of people living with the conditions or symptoms we are trying to treat or prevent. This is already baked into the NIH HEAL initiative, and these partnerships between communities, people with lived experience, and scientists are vital to the success of whatever research priorities are set. For me, this means meaningfully integrating the knowledge and insights of people with lived and living experience of pain across the lifespan throughout the entirety of the research process. From setting priorities, as NIH is currently doing, to study design and data collection, analysis, and interpretation, to dissemination and implementation in the real world, from urban centers to rural areas and everywhere in between. To be successful, we have to prioritize building trusting relationships and facilitating collaborative partnerships between researchers and communities, between people with scientific knowledge and expertise in pain and people with lived knowledge and expertise in pain. I know I'm going a little bit over, but I'm going to close with this quote from me and my co-chair of GAPA, Blair Smith, which we recently wrote in response to the impact recommendations that include this as well. By bringing scientific knowledge together with the knowledge gained from lived experience, better research questions may be asked, even at a molecular or mechanistic level, and more innovative and transformative treatments may be discovered. And I'll add optimal to the mix and end there. Thank you.
Thank you so much. Wow. Okay. That's powerful. Sorry. Moving on to Dave. I think, is Lloyd going to share your slides? Would you like me to, or are you going to share them yourself?
I know someone else is driving. I've never done that before, so I don't think today's a good day to try that.
I'm happy to. Oh, go ahead.
I can pull.
Okay.
I want to thank Joletta for her wonderful presentation, and just say that it's an honor, Joletta, to partner with you in our work group. Just waiting for the slides to magically appear.
I have them, Lloyd, if you'd like me to share.
Oh, wonderful. Thank you so much. It's my pleasure to be able to share my journey, and I think it'll be interesting to see how I've grown from a person who hasn't taken a science course since high school to being with all of you here today. Next slide, please. I'm a dialysis graduate with honors, but I definitely didn't start out that way. And I'm going to tell you all about the meeting that turned my life around by challenging me to take care of my own health outcomes, or take charge of my own health outcomes. Next slide, please. These photos cover a lot of my life. The upper left, that's me as a healthy high school freshman back in, well, we did have color film back then, but we didn't use it for that photo. That was when I was a high school freshman. Now, a quarter century later, I was a successful IT manager at a law firm, but I had a lot of unhealthy habits, like smoking cigarettes, drinking too much alcohol, very unhealthy eating habits, and worst of all, not getting annual checkups. Let's fast forward to Thanksgiving Day 2006. That's the photo on the upper right. I'm posing with my brother, sister, and my mom, and my unhealthy habits are really starting to show in a lot of ways. About a year earlier, I resigned from my job to take a career break, but when I did that, I didn't take the opportunity to change my lifestyle. Now, the photo on the lower left was taken in the spring of 2009, and I'm ecstatic because I can fit into my high school basketball warm-up jersey again. Someone else you've heard of has worn a very similar jersey for the same high school, and that person's name is Dr. Anthony Fauci. Now, back then, the pounds were melting off, and I really didn't care why, because I looked better than I had for a long time, and I was eager to return to work. But at the time, I didn't know that unexplained weight loss was a cause to concern, but I found out that it was 6 months later when I landed in George Washington University Hospital's emergency room and found out that my kidneys were no longer working. And less than a week later, I stopped making urine completely. And I ended up spending 3 weeks in the hospital, and I left it with a cane and a limp and a terrible attitude. And shortly after that, I found myself in a dialysis clinic for the first time, and that was a brutal time for me. I hated dialysis from day one, and money was tight at the time. And the cab fare to and from the clinic was $20 each way, so I skipped a lot of dialysis sessions. So many that one day the charge nurse told me that if I missed 3 sessions in a row, I'd have to be dialyzed at the hospital before they would admit me again. Now, that's what she said. But what I heard her say was, you can miss 2 dialysis sessions and you'll be fine. For 6 months, I came up with one reason after another to miss dialysis because I didn't think it was that big a deal. Next slide, please. Now, that all changed after a care plan meeting at the clinic, and everyone took turns telling me what I was doing wrong. But then I was asked why I wasn't going to dialysis, and I explained that $40 a day was a big barrier, for transportation. So we spent the rest of the meeting putting a plan of action together, applying for Social Security disability, getting a paratransit card, and signing up with the food pantry. And at the end of the meeting, that same charge nurse said, we're going to do your part, but you have to do yours. And if you don't start going to dialysis 3 times a week, you won't be around much longer. And a few hours later at home, that message really sunk in. I was in my bathroom. I'll never forget. I looked myself in the eye and I said, this is on you. No one can do this but you, and it's time for you to step up. And that's what I did. I changed my attitude toward dialysis and towards life itself, and I promised myself that I would go to dialysis 3 times a week, no matter what. And it wasn't easy, but I kept that promise. Next slide, please. After a couple of months, I started to see a change in my attitude, but not so much in how I felt. So I thought about other things I could do to become healthier. On New Year's Eve 2010, I smoked my last cigarette, and the next day I started exercising again. And I was shocked when I discovered that I couldn't do a single push-up anymore. And that moment changed my life. And then the next morning, when I got up, I asked myself 2 questions. The first one was, do I have time to exercise? And the second was, am I physically able to exercise? Now, some days I couldn't exercise because I was in pain for one reason or another, and I knew that working out while you're in pain wasn't a good idea. But on the days that I could answer yes to both questions, I got in a workout, no excuses. And I asked myself those questions day after day, and exercise eventually obliterated my frailty. I went from being anemic and needing a cane to get around to running hills and being well on my way to over 100,000 push-ups, and eventually being waitlisted at 3 different transplant centers. And I finally got the call for a kidney in 2015. And by the way, I'm up over 200,000 push-ups now. Next slide, please. Many people who are on dialysis experience chronic pain. I certainly did when I started. One of the benefits of becoming stronger was that exercise became easier. Dialysis became easier to endure, except when my legs started to cramp, or my hands, or my feet. I'll never forget the time that my legs were starting to cramp and I shifted my weight in the chair, and that caused my abdominal muscles to begin cramping. And I started laughing because the situation was so ridiculous. And that's how dialysis felt at times. But there were a lot of good experiences as well. I had a care team that never gave up on me. And my nurse practitioner challenged me to manage my health outcomes by encouraging me to set goals and to go after them. I got so good at managing my health that they would let me change my target weight, which is how much I was supposed to weigh after my treatment. And that got me interested in clinical trials. Once a nurse practitioner brought a group of second-year medical school treatments over to my chair so they could talk with me and learn what being on dialysis was like. Next slide, please. I received my kidney transplant in 2015 at George Washington University Hospital, the same place where I was diagnosed with kidney failure. And earlier that year, I asked my wife if I could pursue a career in advocacy, and she gave me her blessing. So my transplant couldn't have come along at a better time. Next slide, please. I was doing web searches and signing up on mailing lists and applying to join every advocacy group that I could find. And I hit the jackpot in 2016 when I received an email from PCORI inviting me to join its advisory panel on patient engagement. I'll never forget during the discussion in my first meeting there, everyone started talking about PIs, and I had no idea what a PI was. The only thing I could think of was a private eye, like Magnum PI. I'm probably dating myself there. Next slide, please. Around the same time, I was invited to join the Kidney Health Initiatives Patient and Family Partnership Council. That's the photo on the right. KHI is a public-private partnership between the FDA and the American Society of Nephrology. And our mission is to catalyze innovation and the development of safe and effective patient-centered therapies for people living with kidney diseases. These photos were both taken in 2019 when I chaired both groups simultaneously. And I also returned to the workforce that fall, and that's not all. Next slide, please. That summer, I got an email from a kidney disease researcher who contributed to a paper that I referenced in an article I wrote about the need to develop better options for pain management for people on dialysis. She was responding to a request for proposals to fund the study of pain management and opioid reduction in people on hemodialysis. And that was an invitation that I couldn't turn down. And apparently neither could NIH HEAL. Next slide, please. These are photos of my fellow HOPE Consortium patient advisors, and HOPE stands for Hemodialysis Opioid Prescription Effort. We all experienced challenges with staying involved at some point in the trial, and we endured loss and personal hardships. One of our colleagues, Robert, passed away during the study, but we also enjoyed some wins as study advisors and in our individual lives. When the study began, I was the only person on this slide who was a kidney transplant recipient, but that is no longer the case. The next slide, I think, is my last one. The trial ended earlier this year, but the writing group remains active. We just shared our results at a late-breaking clinical trials plenary session at the kidney conference last month, and we are still publishing. And I'll end here in the interest of time by saying that I agree with Joletta 100%. And I challenge us all to think about how we can integrate more people with lived experience into the research community as partners. Thank you.
Thank you so much for sharing your story. Wow, we are so fortunate to have you and Joletta as part of our working group and on each of these subtopics. So really, really appreciate all of your contributions to the larger efforts and to our work group. Okay, so we'll launch into the scientific talks at this point. Our first group to go is going to be Meryl and Katie. And they're going to be introducing themselves and their group, which is focused on enhancing care delivery. So if you want to go ahead and share your slides and introduce yourselves more fully, I'll turn it over to you. Thank you.
Great, thanks so much. I'll go ahead and share. Let's see. Can you see that?
Yes.
Okay. We'll start with just a little bit of introduction. So my name is Katie Butera. I'm an assistant professor at the University of Delaware, and also a pain researcher. Meryl and I will be presenting today, although just acknowledging that David was also part of our, Dave was part of our work group as well. Meryl, do you want to say a little bit about yourself too?
Thanks everyone for being here today. My name is Meryl Alapatu. I'm a research associate professor in the Department of Physical Therapy at the University of Florida.
Great. Okay, so and I just want to make a quick acknowledgement too, as we went through some of these slides or some of this presentation, Julie Fritz from the University of Utah shared some of her slides and bullet points with us as well. So just wanted to make that acknowledgement. So our subtopic was, as part of this focus group, was enhancing care delivery models. What we thought about when we were thinking about some of the research priorities that we hopefully will get some input from all of you on, what we thought about was really the critical need to deliver evidence-based pain management in real-world healthcare settings. So a lot of research, we know has shown that non-pharmacological interventions are safer and they can be more effective than opioids, but they aren't always being delivered effectively in real-world health settings. We also know that undertreatment of pain disproportionately affects underserved populations. So there's many access barriers to access that also impact many groups of people from getting that evidence-based pain management that we hope can be really helpful to them. And what we thought about was really the need for more rigorous designs to optimize the structuring and the timing of non-pharmacological interventions so that they really do work in those real-world health settings when you're translating them from a lab setting or from a research setting. Some current limitations to this are that interventions and delivery models with promising efficacy are not necessarily successful when being translated to clinical settings, and that has to do with differences in the health systems and differences between healthcare settings and the research setting. You often find barriers that you hadn't considered, and you might find facilitators that you didn't know about that could impact that delivery. So we want to think about that when we're moving forward with optimizing intervention delivery. There's also variations in practices for organizing and delivering non-pharmacological pain management, and we don't always know what the right timing is, what the right sequencing is, and who might respond appropriately to those interventions. And finally, because so many individuals across the nation and internationally are living with chronic pain, there's many providers who those patients get in front of, and sometimes there's a limited clinician adoption of evidence-based interventions or lack of adherence to recommended practice guidelines. And again, that's not necessarily because the clinician doesn't know what those interventions are, but might be because they just aren't able to deliver those because of the barriers that exist within their environment. So our proposed research priorities are that we'd like to get some input on for this subgroup or for this subtopic. I'll be talking about the first one, and then Meryl will be talking about number 2 and 3. So that is, the first one is to utilize advanced trial designs such as SMART designs to determine optimal combinations and or sequencing of pain management interventions and to explore the predictors of success or responsiveness across patients. Our second research priority would be to support garnering more support for pragmatic research initiatives that are critical to implementing some of the care delivery models that have shown previous efficacy in a research setting. So some examples of those would be stratified care or stepped care models. Also, being able to identify barriers and facilitators of intervention delivery across various health systems. So not only are health systems different from research settings, but there's differences between health systems that we want to consider. And then also within that, ensuring intervention access for underserved populations. And then our third research priority is to identify and evaluate effective models of telehealth, hybrid care, and AI-driven interventions. So I'm going to start with talking a little bit about the first research priority, and then Meryl will take the second and the third, and then when we're done, we'll have a little bit of time for discussion. So again, this first research priority is to utilize advanced trial designs to determine optimal combinations and/or sequencing of pain management intervention and to explore predictors of success and responsiveness across patients. Again, this research priority really comes from not really understanding how to combine interventions effectively together so that we really are seeing the most benefit in our patients. And why we use a SMART design? So a SMART design stands for sequential multiple assignment randomized trial. So when you're in a clinical setting and you're delivering pain management, many decisions come up. So if the patient isn't responsive to initial intervention, what should I do next? Or once the patient recovers, what's needed to prevent them from having that pain condition or that chronic pain relapse? A treatment's effect may be also impacted by what comes before or after. So did they see PT first? Did they get opioids first? Were they doing self-management before they came into physical therapy? So those are just some examples of how different sequencing might impact their care experience. SMART designs also provide insight regarding the best sequencing of treatment, best timing for treatment alterations, and then really provide some information for clinicians to really understand how they can adapt and change their interventions based on their patient's responsiveness. So Dr. Fritz and her group published on a SMART trial design. So I just wanted to give an example of what this would look like in a research setting that could really be translated more easily to a health system, because you're really dealing with differences in different dynamic treatment regimens. So some people end up getting physical therapy first, for example, or cognitive behavioral therapy, and then might switch to another intervention. So in this study, they showed how they enrolled their participants, they randomized them to either a physical therapy or cognitive behavioral intervention. They took an assessment later to see if the patient was a responder or not responding. And then they had some decisions in terms of if they were responding, maybe they would maintain that interventions, versus if they weren't responding, then they would switch to a different intervention. And so you can see in this that there were 4 dynamic treatment regimens that were looked at in just this one study, and really we could gain a lot of information, or they were able to gain a lot of information about how this type of decision making might look and how patients might respond in a real world sequencing. Okay, go ahead, Meryl.
Right. The second research priority, as Katie described, is expanding support for pragmatic research initiatives. And so 3 examples of care delivery models to examine pragmatic approaches include stratified care, step care, and then sequenced care. So risk stratified care assumes that patients at risk for poor outcomes can be identified early on when they seek care, and then providing them with targeted interventions aimed at reducing their risk of poor outcomes will lead to more positive outcomes. By contrast, stepped care assumes that providing all patients with a core or basic treatment that supports self-management of their symptoms will lead to improvement for a substantial number of patients. And that for patients that don't improve, they're not going to be harmed by waiting for more comprehensive treatment to be initiated. And then finally, sequenced care involves delivering care in a pre-planned order. And so this next study that it's an ongoing study that I'm going to describe, incorporates aspects of these 3 different approaches. Next slide. So this is a study led by Susan Hastings and Steve George. This is a VA-based pragmatic cluster randomized comparative effectiveness trial. Basically, this study involves two different clinical pathways for low back pain, with the primary outcomes being pain interference and physical functioning. So the first care pathway is using a pain navigator within the VA system that facilitates the coordinated use of existing VA and non-VA pain management resources. So this approach involves a shared decision-making process that includes informing patients with low back pain about clinical practice guidelines, and then provides veterans an opportunity to work with that pain navigator to decide on which services are most appropriate as next steps for their care. The second pathway, which is pictured here, is a sequenced multimodal integrated approach that involves a referral to a PT from a physician after someone has reported low back pain. All patients then undergo this home-based self-management approach. They follow up with the physical therapist, and then they're stratified to different risk groups. So moderate or high risk or low risk. Low risk patients are discharged, and then moderate or high risk patients, again, these are the patients at risk for poor outcomes. They go on to receive psychologically informed care that involve pain coping skills and different behavioral activities. Next slide. And finally, the third priority involves identifying and evaluating effective models of virtual care. So telehealth, hybrid care, and AI-driven interventions. The overarching goal of these virtual models of care is to address pain and quality of life. So when we talk about underserved populations, particularly those who don't have access to rehab providers due to where they live, to high copays, or simply lack the ability to participate in weekly or more often than that in-person visits, understanding the extent to which virtual and or hybrid services for pain are effective and are warranted. So although telehealth and rehab is not new, it's been around for some time. During the COVID-19 pandemic, many rehab providers were forced to move their services online. And even with the return to in-person services, telehealth has remained a popular mode of care for rehab providers, and many integrate a hybrid model as well. So when I say telehealth, I'm referring to consults and treatments that are delivered virtually. So everything is online. Hybrid or integrated care is a combination of in-person and virtual care. So maybe the first assessment or examination is online, and then subsequent or follow-up visits are done virtually. And then over the last few years, AI-driven approaches to rehab have become more common in practice, but empirical work in this area still remains scarce. So AI-driven care can involve the use of technology such as motion sensors or different apps to assist in the diagnosis, assessment, and then also of different issues that patients may be experiencing, and then also can help with developing personalized treatment plans. So AI-driven care may include motion analysis, may include remote therapeutic monitoring, and then studying these models of care in comparison to more traditional approaches of rehab. Okay, and I think that is it for us. And I think we've got a few minutes to take questions.
Yeah, and I'll just say thank you so much. We're definitely interested in getting input on the research priorities, and I can also put those back up as well.
We'll probably save digging into the research priorities for the end. We have some time designated for going over those, but if there's any clarifying questions,
great.
We have a couple of minutes if there's any questions specific to the materials you presented.
Thanks, Claudia.
Okay, we do have something in the Q&A box. Hello, I'm both a researcher and intractable pain patient. Are the studies that you've mentioned regarding the participants ones who do not have structural issues and or those who have had corrective procedures done?
I believe the VA study is open to anyone who's seeking non-pharmacological care for their pain. So they would not be limited by whether or not they have issues, herniated discs or stuff that shows up necessarily on an MRI or other imaging, but anyone who reports back pain and is open to enrolling in a non-pharmacological, a study that involves non-pharmacologic care as one of the arms they're randomized to.
Yeah, and I would have to look specifically at the study from University of Utah, but again, that one was just an example, and that was low back pain as well. So these are just examples of the trials that are types of designs that could be used. So I would have to look to get that more specific information.
Great. Thank you for answering live. We have another question. Are you differentiating between chronic pain and chronic secondary pain before you try to put the patient on one arm or another?
So neither of us are directly involved in these studies. So these are just examples of different models of studies. So I mean, we would have to consult with the principal investigators to dig in more specifically to the inclusion criteria for these studies.
But in general, with this kind of study, would you think it would
Yeah.
make sense to differentiate between the two?
That's what I was going to say. I think that is definitely like an open question, and why something like these types of would be, really important to consider. Considering the individual's experience before and after might be impacting whether they're a responder or not to a certain intervention. But by having that information and then putting people into these randomized, like individuals or patients into the randomized trial, knowing what their history is, and then seeing how they may differ in their pathway. I think that it is what these types of, like, especially with a smart design, really are looking to examine and understand more about.
Well, I think that with the stratified care approach, the second phase of that VA study, that's what that is aiming to do as well, is if there are patients that are moderate risk or high risk for poor outcomes based on the presence of different psychological factors, providing them care or treatment that's aimed at those is the goal of that.
Thank you. Okay, we have some additional great questions coming in. I'm just gonna make note of them for us to dig back into them when we have our designated time for that. Right now, let's go ahead and move to our next presentation. It'll be from the Personalized Pain Management Priorities Group, led by Fanan Razu, Renee Manwaring, Asaf Bari, and Joletta Belton. So I will turn it over to you all to introduce yourselves. Thanks.
Hi, thank you, Claudia. Can everybody hear me okay? Yeah, super. All right, let me go ahead and share my slides. Okay, perfect. All right, good morning, everybody. Today, we'll be talking about personalizing pain management and moving beyond the traditional sort of one-size-fits-all approach. My name is Fanan Rasu. I'm a clinical psychologist by training and assistant professor at Johns Hopkins, where I work with folks living with chronic pain in the clinic, as well as do related research. I'll be presenting along with my colleague, Dr. Renee Manwaring. Renee, if you want to go ahead and just briefly introduce yourself.
Sure. I'm Renee Manwaring. I'm a pediatric pain management specialist at the University of Texas at Arlington.
Lovely, very good. So today, Renee and I will be sharing our vision for how personalized medicine can transform pain care. As you can see by the title on the screen, the presentation is called Move Beyond the Bell Curve.
How are you doing? Okay, we're just doing some window cleaning. You have some guys on the floor. Sorry.
While standardized approaches have served as a foundation for pain management, in 2024, we now have the capabilities and the evidence to move beyond these more standard approaches to more personalized strategies to better account for individualized differences in the pain experience and treatment response. So as part of the larger HEAL strategic planning initiative, Renee and I are going to outline some key priorities for advancing personalized approaches to pain management. So let's go ahead and get started. So let me just go ahead and just start by highlighting why we need to move beyond our current approaches to pain management. Right now, we see a number of critical challenges. First off, our current approaches tend to overlook individual differences in how people experience and respond to pain treatments. We often use standardized protocols that don't necessarily account for unique combinations of biological, psychological, and social factors that we know can influence each person's own pain experience and their response to treatment. Next is the sort of overwhelming economic impact that ineffective or suboptimal pain management can have. And just by some latest estimates, $635 billion annually is spent in medical care and lost productivity, which is obviously a big concern. And finally, the most important, or what I see as the most important thing is we see a wide variation in treatment success across individuals, regardless of treatment modality. And this bell curve on the screen over here just sort of illustrates how our current standardized approaches might work well for some individuals who might fall in the middle of the bell curve over here, but maybe not as well for folks who fall on either end of the curve. Some patients may be being overtreated while others are potentially receiving inefficient care. And these challenges point to an urgent need for move beyond to more personalized approaches. Now, the timing for personalizing pain care, like I mentioned before at the beginning, is never been better. There are a number of key factors where I think why we're at the opportune moment to be able to do this sort of work. First, we have an unprecedented advances in analytical capabilities. Like our colleagues mentioned before earlier in their talk, with the advances in computer technology and AI and the power available today, it can allow clinicians and researchers to process and analyze complex data in ways that maybe weren't necessarily possible even a few years ago. They have the potential to integrate multiple streams of data, from genetic information to real-time symptom tracking, to better understand individuals' responses. Also, there's a growing body of evidence demonstrating just how differently individuals respond to different treatments, and a growing body of research is just continuing to show that what works extremely well for one individual might be problematic for another. And there's just a lot of mounting evidence demonstrating the challenges that a traditional one-size-fits-all approach can have. Also, there's increasing demand, finally, amongst folks with lived experiences, patients, and communities to be actively involved both in research and treatment decisions. People with lived experiences of living with pain are often pushing for more collaborative approaches to not only research but care, and the right to do so. The shift towards shared decision-making and meaningful community engagement is truly important for pushing towards personalized pain management approaches. But before we can fully realize this personalized pain management approach, we have to acknowledge a couple of key challenges. First, we lack comprehensive models for risk assessment, recognition of pain patterns, and prediction of treatment responses. While a number of people have made leaps and bounds in developing predictive tools, we don't have yet fully validated models to integrate multiple aspects to help guide clinical decision-making for clinicians in the front lines. Even if we were to have these models, there's struggle with integrating them into healthcare systems into clinical practice that is effective and actually useful for clinicians. And this isn't necessarily just a technical challenge. It sort of goes beyond that. Our current healthcare system, I think, is structured in a way to support. It isn't necessarily structured in a way that can fully support these personalized approaches for pain care from both operational and reimbursement perspectives. Also, many providers lack adequate training in personalized approaches, and more importantly, there are few, maybe incentives for them to adopt these methods. And when faced with time pressures that clinicians often are experiencing in the clinic, as well as reimbursement constraints these clinicians often have to default to standardized protocols rather than tailoring it to the needs of the patient in front of them. We also have to acknowledge another challenge is generally historical exclusion of diverse perspectives in pain research. This has led to a number of different gaps in understanding how pain and pain treatments affect different populations, and it limits our ability to fully develop truly comprehensive pain protocols. And while these challenges are significant, they're not necessarily insurmountable. And what I'd like to do now is transition to a couple of the priorities that our group has think will be really important for moving forward in this field. So the first priority is developing comprehensive models for personalized pain management, as illustrated in this this diagram over here. We envision these models integrating a number of different domains, integrating multiple determinants of health, including biological, psychological, functional, and social factors. We believe that each of these components plays a crucial role in understanding the experience and response made and need to stop being looked at in isolation. We also need to leverage multiple data sources, including genomic information, to understand genetic predispositions, biometric measurements to track physiological responses to everyday experiences and related treatment. And critically, and I think really importantly, is incorporating patient self-measurements and preferences to be able to integrate both some of these objective measures as well as these experiential measures to truly make sure this is patient-centered. And then finally, we got to make sure that these models are validated across multiple populations. We can't just move forward with assuming that what works from one population is necessarily going to translate to another population. This validation piece, I think, is incredibly important for making sure that these methods are truly inclusive and effective. And like I mentioned earlier, we got to make sure that we're doing these in partnership with patients, community stakeholders, folks with lived experiences, and making sure that we're incorporating their perspectives to make sure these models are actually going to be working in the real world. Now, at this point, what I want to do is I want to hand it over to Dr. Manwaring, who's going to share a couple of additional priorities and share some specific cutting edge examples of how these models might be developed and implemented.
Great. And if you can continue to, I'll tell you to move the slides, that would be great. So what makes a good model? First, we need multiple data points. And most people on this workshop, I think, are familiar with the biopsychosocial model. You may have noticed we added function because of our ability with sensors to be able to identify function and remotely monitor function. We know that pain, though, is a subjective experience. And as Margot McCafferty, one of the founding neuroscientists, stated, pain is, back in 1968, pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. And that emphasizes that personal experience that often gets honed down to asking on a 0 to 10 scale, giving 11 choices for how you're pain. And while a 0 to 10 scale is inexpensive and feasible, it really gives us very imprecise data. And our persons with lived experience, Joletta and Dave, did such a great job of telling us about their experiences and their trials with pain. It was so much more, their stories were so much better than just a number on a scale. So what do we need? We need valid, reliable, clinically useful pain risk prediction and diagnostic models that with precise objective measurements to supplement those subjective reports of pain. For example, we know that the opioid use disorder prevalence is about 6%. Given research funded by the NIH, we now know that prevalence increases to 8% if you were legally prescribed an opioid as an adolescent or young adult. But rather than focusing on those at increased risk, consensus statements, guidelines, and even laws now recommend just don't prescribe opioids to children and adolescents. And since that's the population I care for, it's concerning to me. We're ignoring that it may be effective for 92%. And we're saying that that risk of an opioid use disorder means that we cannot use these medications, optimize current treatments because of this potential risk. Keep in mind, too, that deaths from opioids, specifically non-prescribed opioids, have continued to increase. So we need more precise predictive models. Second, model development requires systematic validation. So the figures on this slide are from our unpublished findings from our NINR funded study to identify post-operative complications using consumer wearables. Our engineering postdoc, Rui Hua, added biorhythms as a clinical feature after he heard our interdisciplinary clinical team talk about how patients' pain and how they look with pain and their behaviors and their functions are very different when we say 6 hours post-op. If 6 hours post-op ends up being at 2 in.the.morning versus 2 in.the.afternoon. And I hope you're all doing different things at 2 in.the.morning than you are at 2 in.the.afternoon. But by adding that biorhythm feature, our model can now identify surgical complications, specifically infection, about 24 hours before parents or patients report abnormal symptoms. Furthermore, the model can differentiate abnormal symptoms like pain of 5 out of 10 from abnormal symptoms associated with complications like pain 5 out of 10. So now we can address, do we treat the pain or do we treat the pain and look for an underlying cause for the pain? Third, does this have real world clinical utility? So a different interdisciplinary research team that I lead developed a machine learning needle pain recognition model for infants, and it's 98% accurate. But I don't really need a computer model to tell me that when I poke a kid with a needle, it's going to hurt, or when I pierce that skin. So thanks to National Science Foundation funding, we are retraining that model to recognize postoperative pain and alert nurses. We hope to use it to continuously monitor pain and essentially functioning like a nurse call button for babies. Okay, next slide. So the models must be feasible to implement. When I read clinical efficacy reports for pain treatments, I notice that sometimes worse pain is reported, and sometimes average pain is reported, and sometimes change of pain is reported. So the top figure is all the daily pain scores for 49 patients before and 1 hour after pain treatment, as reported for 21 days after surgery. Which number is most important? What's the most precise for recommending or optimizing pain treatments? Keep in mind, when I take a blood pressure as a nurse, if I don't like the number, the first thing I do is tell you to relax, uncross your legs, and then I'll take another blood pressure. And if I still don't like the number, I might wait a little while and then I might take it a third time. But I don't write down all three. I write down the one that I think is meaningful. You saw in that previous slide that we had heart rate data. We can also get all the blood pressure data. We can get all of the information now from these monitors, and these models can use all that data to pick up signals that I may not have thought was meaningful in the time, in my shift, in my visit, but are meaningful across time. By involving community partners, we can get data to develop better models to guide treatment decisions and to optimize treatment responses. For example, homo opioid use is routinely measured by self-report. Since all published studies have thrown out whenever the patient reports using more than prescribed. So if they were prescribed 20 pills and they say they used 25, they throw out their data. Therefore, it should be obvious that you're going to end up showing that people use less than they are prescribed, because we only keep the people who said they used less or used all that was prescribed. In the graph at the bottom of this slide, we report what those same 49 patients said they took for pain. Note, and I know it's really, really hard to see because it's so little, but you can look at the reference. But some of the medications and that patients used were actually not analgesics at all. We also tracked opioid use using electronic pill bottles. It would tell us when the pill bottle was open. We found that the pill count was not associated with the self-reports of pain and medication use, but that the pill counts were associated with how many times the bottle was opened. And we actually had very good association. We also, though, found that unreported pill bottle openings happened on weekends and 7 to 10 days after the last self-reported opioid use. Is that perhaps opioid misuse? But was the use of the electronic pill bottles acceptable to our community? We enrolled 100 patients in this study. We only gave data on 49 because only 49 brought back the pill bottle and for us to get the data from. All of the patients were told that that's what the pill bottle did, and this is what we were looking for. Perhaps this was not acceptable to our community, and so we need that community response. Next slide. So this photo is of my daughter and I 39 years ago. The day she was leaving the hospital, it's the only picture I have after her open heart surgery. Like most infants at that time, she was given an anesthetic. She was not given an anesthetic or an analgesic for her surgery, just a paralytic. She wasn't even given Tylenol. I was told at the time that babies didn't feel pain. And that's really why I dedicated my life to making sure that this never happens again. I don't think in about 2 years after this picture was taken, Dr. Sonia Nod published a study showing that the risk of death actually increased dramatically when babies did not get anesthetics or analgesics for postoperative pain like my daughter. But we have this tendency to throw out the baby with the bathwater. In fact, in our study of the genetics of pain sensitivity and analgesic metabolism in adolescents and young adults with sickle cell disease, we asked healthcare professionals about their use of genetics for pain care. And first they stated they didn't know about pharmacogenetics or how to find the genetic information of pain care. And while they agreed training might be helpful, even I had never scrolled down to the bottom of the patient's snapshot in the electronic medical record number, where the pharmacogenomic results were given with clear indications of how to use them. So do prescribers now scroll down, or is there a better workflow integration? Is there a way to put this really right there in front of us and say, this is important information for you to use? We need to learn from diverse healthcare contexts. This brings me to the Childkind International logo. Childkind is a voluntary nonprofit organization that recognizes hospitals for being sensitive to children's pain. Unlike CMS or the Joint Commission, Childkind is the carrot, it's the reward for a job well done, not the stick, not penalizing you for not doing it a certain way or doing it the same way for all patients. 4 of the 19 Childkind hospitals are in Chicago, where I led a collaborative effort to make sure all hospitals where children receive care were sensitive to pain for the past 8 years. Childkind hospitals must demonstrate training for healthcare providers. They have to demonstrate that they have a way to assess pain, treatments, to escalate pain care. They have to demonstrate metrics for performance, how they react to those metrics for performance, and a willingness to share lessons learned. But does that mean that pain care for children in Chicago is better than children in other cities? Is pain care better in healthcare systems that received the most NIH funding or in their cities? And shouldn't that really be studied? Next slide. So as I previously mentioned, my daughter didn't even get Tylenol. This over-the-counter infant Tylenol is still not approved for use in infants. We need to ask people with pain, with lived experience of pain, what works and what they're using. So I shared with our group that I hear about 2 to 3 advertisements for pain treatments during my commute to work, all followed by a really fast-talking person that says that these claims have not been proven. Consider the cost of these ads. Are these companies and healthcare providers avoiding the FDA approval because advertising direct to the consumers is cheaper than conducting a really good pragmatic trial? Consider the cost of healthcare. Are people using these products because they're less expensive, more accessible than traditional healthcare, or more effective than traditional healthcare? Or are there barriers to traditional healthcare and effective treatments? So now I'm going to return you back to Dr. Faynan Rasu to tell you the path to optimizing pain treatments. Like that pictured below, where Ted's pain cream has been switched to Greg's pain cream to try and personalize it for Greg.
Thank you, Renee. Yeah, so let me just go ahead and conclude by outlining what we see as the path forward and its expected impact. On the path of success, we feel that there are a number of different essential areas and elements that are important. First, we need to make sure that that folks who are engaging this are performing stakeholder engagement early on, bringing patients, providers, loved ones, researchers, community members together from the start, from the very beginning. We also want to make sure that we're performing systematic validation of personalized approaches across different populations and settings. And then we want to make sure that there are continuous feedback loops to refine and improve these methods based on actual real world implementation. And by following this path, we expect to see a number of significant impacts, including reduced trial and error treatment approaches, getting patients to effective treatments more quickly. We also expect to see folks achieve more efficient resource utilization by matching treatments to patients who are more likely to benefit much earlier on. And then finally, we expect to see improved outcomes for folks living with pain. And this approach, this personalized pain management approach, we feel represents a careful, systematic way of directly leading to meaningful improvements in pain care. And by following this path and staying committed to personalization, we believe that clinicians and researchers can truly transform pain management from a one-size-fits-all approach to one that actually serves each individual's needs. And with that, I just want to thank you all for your attention, and thank you.
Thank you. Terrific presentations. We have some really good questions in the chat. I see that some folks, it looks like Renee and Fanan are already starting to work on answering those around complex interactions, pharmacogenomics, and how we might be able to incorporate those features into pain management, and also questions about opioids. These are all terrific questions. I invite our excellent panelists to respond in the Q&A, and that I'm also making some note on old-fashioned hard copy here that we can come back to all of these at the end as well, while we move on to our next presentation, which is going to be the prevention across the lifespan group. And so inviting, oh, perfect, already sharing slides. We've got Jennifer Rabbits, John Farrar, and Joletta Belton on this subtopic.
Hi, Claudia. Let me just get my slides sharing here. Do you see those?
Yes.
We do.
Okay. All right. Okay, there we go. Now I can see them as well. Thanks very much for the opportunity to speak here. I'm Jennifer Rabbits. I'm professor of anesthesiology, perioperative and pain medicine at Stanford. I practice clinically here and serve as chief of pediatric pain, and also lead a research program that I'll tell you a little bit about some of the work that we're doing. John, would you like to go ahead and introduce yourself as well?
Yeah, I'm John Farrar. I'm one of the co-directors of this group, and I'm a neurologist and epidemiologist interested in pain and clinical trials at the University of Pennsylvania.
And then we already heard from Joletta Belton, who's our partner with lived experience, who worked with us on this panel. And so we've been focused on the proposed priority of prevention of pain. And so that's what I'll talk to you all about today. I'll start with where does prevention fit into HEAL, and take a look at what's already currently being funded in prevention research within the HEAL initiative. And then I'm going to focus in on pediatric pain prevention and present our own HEAL trial briefly as an example. And then I'll hand back over to Dr. Farrar to present on prevention in adults, and we'll finish up with discussion of our proposed priority areas. Okay, so prevention of chronic pain is a key goal of the HEAL initiative. Here you can see the overall objective of HEAL, and you can see that in the pain arm, this includes prevention and management of pain. So clearly a key priority. We were tasked with defining our prevention priority, and then, like the other work groups, identifying 2 to 4 priority areas within prevention. And so here is our draft priority statement. So we will advance pain prevention by evaluating primary and secondary strategies to reduce pain and prevent transition from acute to chronic pain across the lifespan. Integrating lived experience, we will assess preventive approaches and implement safe and effective early treatments for novel cohorts, high-risk populations, and for the whole population. And so let's first look at a few definitions. So the Federal Pain Research Strategy defines prevention of pain as prevention of the onset, persistence, and related disability of chronic pain. In the broader prevention research, there's three focus areas in prevention: primary, secondary, and tertiary prevention. And primary prevention is defined as avoiding development of a disease and removing the risk factor. So again, the Federal Pain Research Strategy interprets this for pain research as preventing acute pain in the general population and in high-risk groups. Secondary prevention in the broader prevention field is early detection and treatment to prevent progression of a disease. And the Pain Research Strategy defines this as prevention of transition from acute to chronic pain. And then tertiary prevention is reducing complications of an established disease. And in the context of the Pain Research Strategy, this is defined as aimed at reducing the frequency, severity, and disability of chronic pain. And so where does this fit into all the strategic priorities that we're discussing today, as well as, over the course of the several weeks of priority setting, to kind of understand what's the scope of our work group? So today we're within the intervention work group. And so our priorities are focusing really on interventions that focus on prevention. There are some areas that are related to prevention that are covered by the other work groups that have been presenting over the course of several weeks. So I wanted to just take a little look at that as well. But predictors and biomarkers of pain are obviously key when we think about prevention, and they're really being captured within the biomarkers and predictors work group. Phase 1 and 2 trials for development of preventive treatments are captured within the therapeutics development work group. And then there's also an implementation work group, which may look at implementation of prevention trials. And then there's overlap with health equity and pain across the lifespan, which I will touch on shortly. So we're really focusing our efforts within this priority on interventions that relate to pain prevention. So taking a little closer look, I mentioned the overlap between prevention and biomarkers. So with a prevention lens, prognostic biomarkers may identify individuals who are at risk for chronic pain, and so would be important in identifying individuals to target with preventive interventions. And then predictive biomarkers may identify those who are going to respond to a preventive intervention. But these are really under the purview of the biomarkers work group. So in prevention of chronic pain, it's really important that we take a lifespan perspective. We know that vulnerabilities in childhood and developmental changes in adolescence contribute to onset of pain, and that pain that develops in childhood, adolescence, and young adulthood can begin a trajectory of pain that impacts an individual well into adulthood. And so we see childhood, adolescence, and young adulthood not just as a window of risk in terms of chronic pain, but also really a key opportunity for prevention of pain. And so long-term solutions to the pain and opioid epidemics really must begin with prevention in youth. And so although there is a lifespan perspectives work group, this really can't be separated from our prevention work. So as we set out to develop research priorities, we looked at what priorities already exist within HEAL for prevention research. And so the Federal Pain Research Strategy is what guides current HEAL priorities. And so I pulled out all the priorities listed in the Federal Pain Research Strategy that have a prevention focus. So these include optimizing public health strategies to educate patients on managing pain, evaluating safety and effectiveness of management of procedure-associated pain, optimizing post-surgical approaches for acute pain, evaluating safety and efficacy of early interventions, and determining pain management strategies that will promote or prevent development of chronic pain. And so what research has been funded under these priorities I just showed you? So I reviewed the HEAL clinical pain research programs, which are all listed comprehensively at the HEAL website, and identified a few trials that do examine interventions that aim to prevent chronic pain. And so 3 of these are within the HEAL Effectiveness Research Network. One is our own study that I lead along with Tanya Palermo, which we are aiming to examine the effectiveness of a psychosocial intervention to prevent transition from acute to chronic post-surgical pain. I'll show you a little bit more about this trial here shortly. Also within the HEAL ERN, Dr. Wang and Doan are leading a study to optimize use of ketamine to reduce post-surgical pain. And then thirdly, within HEAL ERN, there's a study examining peer support for adolescents and emerging adults with sickle cell pain to promote engagement in cognitive behavioral therapy. So I think these are, great examples of what's already been funded for prevention in HEAL. The first one is really primary prevention, and I'll show you a little bit about that shortly. The second one is kind of in the secondary prevention domain, and then in terms of youth with sickle cell pain who have recurrent pain, this is in the secondary to tertiary prevention areas. And then there's also 2 trials within the Advancing HEAL Equity in Pain Management program, which do have a prevention lens. Dr. Zev Kane at UC Irvine is leading a study, Latinx Children in Surgery. And this study is testing a web-based pre-surgery intervention that prepares young children for surgery and aims to reduce pain and anxiety following surgery. And then the PAINT project addressing inequities in the emergency department. This study is testing interventions in the emergency department setting to overcome bias in management of pain for children from ethnic minorities who are presenting with long bone fracture or acute appendicitis. I don't think it's specifically studying prevention, but really is targeting predisposing factors and aims to reduce pain. So I also would see this as within prevention. And so now I'm going to focus in a little bit more on prevention of pediatric chronic pain. A recent priority setting partnership in Canada, led by Katie Burney and Jennifer Stinson and others, found that prevention of acute to chronic pain transition is the #1 patient priority for pediatric chronic pain. So they really studied what patients think is the key priority in pediatric pain, and prevention was the #1 priority. So this is really important work in pediatric pain. And so I was also asked to briefly present on our own HEAL trial as an example of pain prevention. And so this study, which I mentioned a few slides back, we aimed to examine the effectiveness of an mHealth cognitive behavioral therapy-based intervention to prevent transition from acute to chronic post-surgical pain after adolescent spinal fusion surgery. And so we had 2 intervention phases. So the first is really a primary intervention or primary prevention intervention. So this is during the month leading up to surgery. And then the second phase is a post-surgery phase during the month after kids go home from the hospital after a spinal fusion surgery. The intervention in both these phases is based on cognitive behavioral therapy, and I'll show you a little bit more detail about that. And then we assess acute pain outcomes and then transition to chronic pain at 3 and 6 months. And so our goal was not just to study the effectiveness of this intervention, but also we're using a factorial design so we can study the the timing of the intervention to be able to optimize treatment. And so we're comparing an online education control program to pre-surgery intervention, to post-surgery intervention, to a combined intervention. So again, we can really learn about the importance of timing as well. During the pre-surgery phase, adolescents complete 3 modules. And really, we're targeting 3 key risk factors. We're targeting teens' anxiety and distress before surgery. We know that sleep is a really important factor in the development of chronic pain. And so we're targeting sleep disturbance in adolescents. And then finally, we're teaching pain self-management strategies. And then following surgery, the post-surgery intervention also has 3 modules. And here we're targeting anxiety and distress after surgery, again, targeting sleep, teaching pain self-management strategies, and then also focusing on getting back to physical activity, so activity pacing and other activity-focused strategies. Here you can see some screenshots from the app because teens engage in the intervention through a mobile application. And some of the skills that they're learning include cognitive strategies like replacing worries, behavioral strategies, which I mentioned, sleep hygiene and activity pacing. We teach kids relaxation skills like deep breathing, imagery, and mindfulness. And then there are videos of teens talking about their own experience when they underwent surgery, which is really very validating for teens who are having surgery and may not know other kids having this type of surgery. We know, sorry, my light turned off. Okay. We know that parent distress is also a key risk factor in pediatric chronic pain. And so teens who are participating in this program, their parents also learn CBT approaches to help parents with their own distress around their children's surgery and pain. And so when we developed our priority areas in prevention, thinking a little bit about where pediatrics fits in and what kind of populations we might study in kids, what type of interventions we may want to test. In terms of cohorts and populations, prevention can really be delivered in many different settings. And just brainstorming here, some of those settings would include primary care, education systems. All our schools typically will have a school nurse, sports programs. We mentioned the importance of parents, and we may be able to engage with parents either through programs at community centers, parent programs, or even maternal health. And then thinking about acute to chronic pain transition, other settings could be the emergency room, sports medicine, orthopedics clinic, or surgery. And then in terms of interventions, prevention really needs to include low-risk interventions. So for example, pain self-management, psychological or physical treatments, complementary and integrative treatments, and then pharmacologic interventions must be low risk and combined with non-pharmacologic approaches when we're intervening in a preventive way. So now I'll hand over to Dr. Farrer, who will talk a little bit further about adults.
Thank you.
I will advance the slides for you if you like.
Yes, that's fine. Go to the next slide, please. A lot of things have been said here already, and the reason for having this complex and busy slide is to make sure that all of these things get mentioned and reviewed, and in the interest of time, we won't spend a whole lot of time on them. But the whole point is that we focus on general habits and in order to try and do something with prevention from the get-go at childhood. And that includes things that we're all aware of: exercise, nutrition, and how to deal with life's problems. And, trying to teach resilience by not overly concerning ourselves about small pains that kids always experience and not making it into something that's bigger. And this includes what happens when there are adults. The prevention of pain also obviously can involve vaccines. Varicella zoster to limit the occurrence of shingles at a later age, including a re-immunization in older adults, vaccines for COVID to prevent the side effects there, improving diabetic control to limit painful neuropathy. So there are things that we can do, as well as attention to psychosocial issues that can increase the experience of pain. Next slide. In terms of secondary prevention, that's really the acute to chronic transition. Studies should promote pain resilience and self-management capabilities. A major issue here is that these patients need to be included in the process of both diagnosing and treating the pain so that they're given some control over things. And there are a lot of different ways of doing these. I won't go through the examples here. Dealing with postoperative pain, a clear issue is in making sure that patients not only understand what the pain is likely to be or how the pain is likely to go, but they're given from the get-go ways that they can be involved in helping to manage the pain and not overly worrying about it, as well as helping them with the power to help themselves. Next one. And then just to finish with the tertiary, is that the primary thing here is that the treatment of pain, which is what tertiary is about, and it's handled primarily by other sections, is that it needs to be adaptable to the patient, to the individual responses, since not everybody responds to the drugs. In fact, most people don't, and to be adaptable to the patient's preferences and what they like to benefit from. What is the most important thing for them to do? And so we need to design individual patient care as a collaboration between providers and patients and have both understand what's best available and how to use it. And we'll go to the next slide. So we have references. Next slide next slide is a list of our priority areas. And in what we'll just mention is that first priority area is an intervention in the whole population, coping with skills and trying to work on interpersonal and neuroscience and the whole host of things that can go into the prevention of pain. Next is to evaluate the effectiveness of those strategies, and that can be really quite complicated since some of what we're recommending is a lifelong involvement. But you can look at novel cohorts and high-risk populations to get some traction on what might help and to test preventive mechanisms, and then settings can include primary care. And go ahead, next. And the third one is potentially to look at sleep as one primary area that's a big deal. So we'll stop there. We are at our time for the next, for a break. And you folks have all been very patient in doing things. And what I would like to do is to suggest that if you have questions about prevention, that you go ahead and put them in the Q&A. And Jennifer and I will try to answer those in writing, and others can look at those things. Jennifer, you can stop sharing, I think. And then we'll come back and have a lot of time for discussion at the end of the presentations. So we'd like to try and get started on time. So we're giving everybody 20 minutes. And so we'll see you all back at 1 o'clock. And we'll get started then. Thank you. Okay. I'll give one more minute just to make sure it's actually 1 o'clock. I guess Lloyd, you had the slides suggesting people put things in the question and answer. And so let me take a second to just encouraged people to put things there. We didn't have time for clarifying questions after the prevention presentation, but we assume that there will be interesting thoughts on that issue, and we are very interested in thinking about that. With that, let us keep going. The next presenters talking about excuse me, optimization and adaptation are Benedict Alter and Jen Gawanter, who worked in collaboration with David White as well. So Jennifer or Ben, you want to share your slides? Great.
Okay, so thanks, John. Can you hear me okay? Yeah. Yes, can you hear me?
Yes.
Okay, good, thank you. I'll introduce myself first. And you
Jennifer, we can't hear you.
cannot hear me?
I can hear her.
I can hear you.
Okay, cool.
Yes, most of us can hear.
I can hear.
Okay, I'm gonna keep going because they said they can hear me. I feel like John's face says he can't hear anybody, but I'm just gonna keep moving. Okay, so I'm Jen Gawanter. I am a researcher at the University of Rochester, and I'm gonna let Dr. Alter introduce himself just really quickly.
Hi, Ben Alter, a physician in pain medicine and neuroscientist at University of Pittsburgh. Thanks, Jen, for presenting.
Yes, of course, you're welcome. And we also, the two of us work together collaboratively with Dave White, who you all met at the beginning. He's one of our people with lived experience members, to kind of modify a little bit the priority we were given, which at the time was called optimization, but what was it called? It was called treatment. I can't remember. We added the adaptation. And so here we go. So the rationale for our priority is that pain is often driven by multiple mechanisms. We know that most treatments provide at best only modest improvements in pain. And it's also generally accepted that comprehensive multimodal care is best. However, evidence to support these optimal combinations of treatments for various pain conditions is limited. And we also know that traditional multimodal care carries both financial and time burden often for patients. And we also know that available drugs for pain target a limited number of mechanistic pathways, even though there are a lot more mechanistic pathways that we see in basic science research that could potentially benefit pain. So this is the overall goal of our research priority, is to address these gaps in pain treatment by providing evidence for optimal combinations of treatments, increasing engagement in multimodal care by identifying barriers to engagement and adherence in these treatments and strategies to mitigate these barriers, and adapting current therapies from related conditions or adapting current pain therapies to different populations in order to increase available components of future multimodal care. And so the first priority, I'm not going to read it again. This is the advancing evidence for optimal pain therapy combinations. And I realize that some of this overlaps a little bit, especially with Katie's priority at the beginning. So one thing we might want to discuss is how to maybe separate those a little. But this was our perspective from this, is that there'd be lots of relevant contexts where this priority could fall in acute pain, chronic pain, the acute to chronic pain transition, as well as comorbidities that are associated with pain, so psychological, cognitive, and physical function. Multimodal care is often the best care for people who have a lot of different comorbidities and trying to improve all of those things at once. And so we thought that things that would fit, designs that might fit well with this research priority were factorial designs, smart designs, and hybrid designs. I'm not going to go into any of them in detail, but if there are questions later, we can talk about what that means for those of you who don't think about clinical trial design as much as some of the other people on the call. So for this part of the research priority, I'm just going to talk about just a few examples that are existing, either already in the literature or currently being performed, that would fall into this type of priority. And the first one is the SCOPE trial. And this is Claudia's trial, or at least Claudia is one of the main people in this trial. So if I get it wrong, please, interrupt me. And please feel free to elaborate if you'd like to. So this is a study that was looking to evaluate the comparative effectiveness of conservative, behavioral, and non-opioid pharmacologic treatments for NeoA. And then among those patients who weren't eligible for conservative treatment or those who were interested in additional treatment after that first phase, interested in exploring the benefits of procedural interventions using a sequential parallel group design clinical trial. So I have listed here what the treatments were, so you can kind of get a sense of what they were trying to compare. So treatment A in phase 1 was best practices, and then B was best practices plus duloxetine, and then C was best practices plus duloxetine plus a web-based pain coping skill. So you can see how this this design really aims to compare not only or kind of the additive effect of different combinations of these treatments. And then in phase 2, they were looking at intra-articular hyaluronic acid injections, steroid and local anesthetic injections, and nerve procedures. So they were comparing a lot of different types of therapies, as well as looking at this kind of two-step of like, you try these conservative things first, and then after that, if those didn't work, you can try these other more procedural-based things. And a secondary goal of this trial was then where this kind of overlaps with the personalized group, looking to see what kind of predictors might we use to see which treatments work best for whom. The second example I'm giving is the synaptic trial. And there are a ton of authors of this. I'm sorry, I can't remember who the first one was, but a lot of people that you all probably know. But in this trial, what they were looking to do is they were looking to compare antidepressants versus a fear avoidance rehabilitation versus the combination. And in the primary phase was this first 4 phases, or the first 4 months, sorry. And this was in people who have chronic overlap or chronic low back pain and also have high negative affect. And the reason for that was the thought was that antidepressants might be particularly helpful in people who have high negative affect. And so what's interesting about this study, again, kind of fits right into this, looking how combinations might work better than single treatments. They were comparing, the combined antidepressant and fear avoidance rehabilitation versus each one separately in the first phase. But then the interesting thing was, again, they were also interested in predictors of what works for whom. And so what they did was they had the second phase where they took non-responders in each of the single treatment groups and either re-randomize them to continue to get that treatment or to get the other treatment. And by doing so, what they were able to do is they were able to get a larger sample size to look at these predictions. Because obviously, when we look at predictions in studies that are powered to see main effects between treatment groups, they're underpowered. So the more people that you can get in those analyses, the better they will be. And so I thought this was a good example because not only was it looking at combinations of treatments versus single treatments, it also had a unique design element to try to maximize the efficiency of the study to ask as many questions as possible, which I think is a really important thing when we're thinking about being efficient using NIH dollars as well as using participants' time. Okay, so the second priority was this idea of identifying methods to optimize patient engagement with adherence to different treatment modalities. And so for this study, or for this priority, we used the example of this Target trial. And this was a cluster randomized trial where they were looking at PCP-delivered guidance-based care versus that guidance-based care plus psychologically informed physical therapy. So interestingly, this is again a study that looks at the combination of 2 things versus a single thing. But the reason that I picked this one out, and it's not the best example of this priority, but what's interesting about it is that the fact that the physical therapy is psychologically informed, in my opinion, one of the benefits of that is that it helps people engage in the physical therapy because they're teaching people about fear avoidance and about pacing of movement, all things that could help someone who, if they came to physical therapy on the first day and it was really hard or they were afraid of doing it, they might quit. And so one of the things that I think is really important for all of these non-pharmacologic interventions, especially ones that are like physical therapy or exercise-based, is how do we get people to be willing to try them and keep doing them? And so that's one of our research priorities. And this is kind of a small example of that. I have to be honest, I was lazy and couldn't find a better example. But I think this gives you a little bit of a taste of what we're getting at in terms of trying to find ways to optimize patient engagement and adherence to these treatments. Oh, sorry, I already said that. And then another one of our sub-priorities was to develop patient-centered treatment planning methods for multimodal care for immediate and profound impact on pain management. And the example we have here is the HOPE trial, and I'm going to turn it over to Dave because he was actually involved in the patient-centered development of this intervention. So I'm going to let him tell you a little bit about that and his experience instead of trying to summarize what I read in the paper.
Thank you, Jennifer.
Yeah.
During phase 1 of the HOPE study, participants were randomized to pain coping skills training or usual care. The PCST training involved weekly live coach-led cognitive behavioral therapy sessions that were delivered by video or teleconferencing for 12 weeks. And that was followed by daily interactive voice response sessions that were 45 minutes, and they were delivered by telephone for an additional 12 weeks. Now, in phase 2 of the study, participants in both groups who were taking prescription opioid medications at an average dose of, I think it was 20 morphine milligram equivalents more per day, were offered buprenorphine. And all study participants were followed for 36 weeks. And the intervention resulted in a clinically meaningful improvement for a substantial proportion of participants. Now, the original proposal or our original aim was to examine whether buprenorphine would be an acceptable and tolerable non-opioid for people on dialysis, but the patient advisors encouraged the investigators to prioritize reducing pain in the dialysis population. And it's a good thing that we did, because as it turned out, not many participants, not as many met that threshold of 20 MME that we anticipated would. And of the participants who did, not many were interested in switching pain medications. That's just how people on dialysis, when we find something that works, we want to stick to it. The patient advisors co-developed the visual materials for the PCST intervention, the informed consent documents, and recruitment materials, including a video that we helped write the script for and played roles in.
Right, great. Thanks, Dave. So this is like a really good example of how getting the patient opinion and experience in terms of what types of interventions they want to see really drove that study and the success of that study. And so then the aspect of this, of our priority is this concept of repurposing clinically available treatments. So we want to explore the potential of these clinically available therapies in pain. And so the example the first thing that comes to mind for me in this part of this priority is pharmacologics. And so the reason for that is, if you look at the NHS recommendations for neuropathic pain, these are the drugs that are recommended: amitriptyline, duloxetine, pregabalin, gabapentin, topical capsaicin, and tramadol. The first 4 are drugs that were repurposed from another indication. So the first 2 are antidepressants, and the second 2 are anti-epileptics. And one of the benefits of looking at treatments that are already approved by the FDA or already clinically available is that they won't get stopped in phase 1 because they're toxic. And so it can really increase the efficiency of developing new drugs for pain. And also, we have a really good track record of doing that versus potentially taking things all the way from animal models into the clinic and having them get all the way to being successful and for patients actually being able to use them. And when we were talking about this, Dr. Alter actually came up with, well, shouldn't just necessarily be drugs. This can also be other things as well. And so, for example, actually, I don't know this to be true, but I'm just going to assume that CBT was developed first in psychiatry or psychology, probably for depression. And then, now we use it for pain. All the time is pretty accepted to work for pain. Or things like transmagnetic cranial stimulation, like those kinds of things. So not just drugs, but maybe other things that are working in other related areas that could potentially help for pain. And so that's all we have. Sorry if it was a little kind of mixed up. We tried to get everything that was originally assigned to us in our priority and put it together in a way that kind of flowed. So that's all we have.
Yeah, thank you very much, Jennifer and Ben. So we're open to questions for this. I don't see any yet in the question and answer, but let me use the opportunity of there being a little bit of extra time here to make the point that one of the issues I raised was listed in the list of potential preventions or tertiary preventions, treatment really of pain, was the concept of trying to introduce patients to physical therapy or non-traditional approaches to pain relief actually in the emergency room. And, the concept being that if they actually meet with one of the practitioners of something that they're going to be prescribed, either could be physical therapy, could be another occupational therapy, or various mind-body kind of interventions if they're amenable, as opposed to just giving them a medication, might be a way to sort of get them into the system, let them try it right when they present with their acute pain, so that they have some sense that it actually might help. And I just wondered what you and Ben might think about that.
Oh, wait, I think someone might want to answer that. Jeffrey?
Oh, this is Jeff Dusek. I'm on with Adam next, but I've just finished an NCCIH-funded multi-site feasibility study with acupuncture for acute pain in 3 EDs across the U.S. Case Western, Vanderbilt, and UCSD. Again, we weren't supposed to look at acceptability, or excuse me, efficacy, but certainly feasibility, acceptability were really strong. So again, and we had a high proportion of integrative approaches being acceptable both to Hispanic, African-American, and Caucasian participants. So we had a high proportion of African-American participants, 42%, which is really quite nice for integrative medicine research.
Great. Thank you, Jeff. Jennifer?
Yeah, so I think, I don't know if I should say, I mean, I guess when I think about complementary therapies, they have very low AEs, and they have efficacy in quite a few studies. For me, I think the important thing now is, how do we implement these, and what do they cost people, and what do they cost the flow, right? So one thing that would be interesting maybe in Dr. Dusek's study is, did it make it hard for the patients to get something else, or did it cause the clinicians trouble? I think those are the kinds of questions that at this point for complementary therapies, how do we get people to engage in them? How do we get people to keep doing them? How do we, make it possible? Those are, for me, the biggest priorities that I think are important, because just like anything else with pain, right? It works for some people and it doesn't work for other people. At least that's what we see in the clinic, and that's what our studies imply, even though maybe we statistically haven't shown that necessarily. So figuring out how to identify who might it work best for, or letting people try it so that they can figure out if it works well for them. I think that's what I would say I'd like to try to focus on.
I'll just jump in. The flow was not impacted. We weren't a burden. We did ask that of providers and nurses, physicians, APPs. So it didn't upset the flow, which we also don't want to do. So just to put that in there.
I think just in terms of our research priority, making a multidisciplinary or multimodal care available in locations which are typically thought to be unimodal, like a drug, I think it has a huge potential. And so I think that would be a great priority to pursue.
Great. Other questions from either our panel members or others? We have about a minute.
This is Dave. I would like to just share that I've participated in 3 clinical trials as a dialysis patient, and one of them, or I think 2 of them, were actually in the clinic while I was dialyzing, and one I had the opportunity when I was doing peritoneal dialysis at home to do at home. And what rang true about all of those trials was that the trial met me where I was. I didn't have to go anywhere, and it met me in an environment that I was comfortable in, and that made participating very easy.
The key point, David, thank you very much. No, that's very, very important. Okay, so I see we have a question, and we'll get to that either in writing or when we have time for discussion in a few minutes. Our last presentation of the groups that we've been dealing with in this optimization effort is Adam Hirsch, who's going to talk about cross-cutting values. And Adam, if you want to present yourself, and Jeff, you can introduce yourself. And Joletta, we met you in detail earlier in the presentation.
Great, thanks. John, can you confirm that you're seeing my slides? Okay.
We can see them. Good.
And hearing me. Okay.
We're good. And
Okay.
yes.
Perfect. Dave's comment from the last session segues nicely into our topic. I am Adam Hirsch. I'm a professor in the Department of Psychology at Indiana University in Indianapolis, and I am speaking on behalf of my group, Joletta Belton, who we met. She is a writer and lived experience research partner from Colorado. And Jeff Dusick is a professor in the Department of Medicine and the Susan Samueli Integrative Health Institute at University of California at Irvine. And so I will be speaking on behalf of the group, but this was a collaborative effort, and I'll pause throughout to allow Joe and Jeff to chime in with additional flavor to what I present on. So our approach was a little bit, to be honest, it was a little bit tricky for us to engage with because we didn't have discrete topics that we could go to the literature and say, here's that, here's a research study on this, that, or the other. So I felt like it would be helpful if we were at least transparent and talked about how we approached this notion of cross-cutting. So we were really trying to keep in mind that our overall topic as a group was on optimizing interventions to improve pain management. And so we're trying to keep this centered in our thinking about cross-cutting themes, or what we call values. So then we said, well, what is cross-cutting? What does that mean? And these are themes that intersect and are relevant to all aspects of the overall topic. And so they're relevant to all aspects of the other presentations that we've already seen today. A lot of this stuff that I will speak to came out in some of those presentations, and other presentations, they were very much imbued with this notion of values. And so then we were also thinking, well, we don't want to be duplicative. So what is complementary to other work groups, and what is complementary to other subgroups? And so other work groups were on optimizing pain interventions. Other work groups that have cross-cutting themes or cross-cutting values, or the intersection of pain and substance use work group, they will present on December 2nd, a webinar. And the health equity and pain across the life course subgroup, who will present on December 6th. And then from here in these presentations, we saw a lot of these themes of cross-cutting values emerge in the talks on lifespan perspective. There was a lot of talks that spoke to individualized and flexible care, adaptation to the patient, their lived experience, their preferences, how they respond to treatment, what other things are coming on board in addition to just pain that need to be taken into account. And then also we've heard about innovative care delivery models, those that involve digital technologies, telemedicine, and hybrid. So then what emerged from the research and discussions with me, Joe, and Jeff? So really we wanted to emphasize this notion of values, these guiding principles, these ways of being and doing that will really inform how we think about optimizing pain treatments moving forward. This came up a lot, but we still felt like it is really important to center this notion of these are partnerships. These are multidisciplinary, collaborative partnerships that are co-equals. So this is meaningful partnership, not a tokenistic approach where you add some or a couple people who have lived experience, for example, or a particular professional discipline, and consider this to be a partnership. We really wanted to emphasize that these are meaningful horizontal leadership structures. And it's a full spectrum approach across the research trajectory. And then finally, another theme that emerged from our discussions was this notion of integration. Integration across modes of treatment, including conventional and complementary treatments. And also this integration is not just additive, so 1 + 1 = 2, but is synergistic, so 1 + 1 = 3. And so then we emerged with these 3 subtopics. And so I'll spend a little bit of time talking about them. One is long-term perspective. One is collaborative research. And the third one is an integrative perspective. So the value of long-term perspective, we put words to this in the following: to emphasize meaningful change over a meaningful time frame. And this is defined collaboratively with people with relevant lived experience. And this meaningful time frame was really important to us because although I'll use terms like long-term, that's different for every person and that's different for every situation. And so we wanted to emphasize not just length of time in terms of calendar years, but how the patients and the different partners define time frame in a meaningful way. To evaluate the long-term effectiveness of treatments, emphasizing sustained improvements in quality of life, improvements in functional ability, reductions in pain-related disability. And so we see this in the very HEAL initiative. This is helping to end addiction long-term. We also see this in the Federal Pain Research Strategy. I just pulled some quotes from the federal, or some sections from the Federal Pain Research Strategy and highlighted areas where they emphasized long-term outcomes, long-term effectiveness, long-term consequences of different types of treatments, long-term benefits and risks, not just the short-term, long-term follow-up. You'll see a pattern here. Long-term safety and benefits. And long-term access to social and economic resources. That's one that is important, but probably gets a little less attention than benefits and risks of specific treatments. It's long-term access to these resources. So I want to pause just a moment there to give Joe and or Jeff a moment to chime in if they would like to say anything in addition to what I've already presented on about our first value of long-term perspective.
I mean, you hit it the nail on the head, Adam. And again, when researchers think long-term, we might think, the end of an ED stay or a month out, whereas a participant is thinking years or decades. So what does that look like? And I know research to be studied over decades is nearly impossible. We have to be mindful of what patients or participants or partners really want to have as a meaningful outcome.
Yeah, I don't have anything to add other than that. I think that those, however that is defined, as you've already said, Adam, and as you just alluded to too, Jeff, needs to be co-defined with the people that are being, I don't want to say being studied, but that they are being studied, and the conditions and the symptoms that they're living with are being studied. So just that collaborative approach that you're going to go into now and defining what long-term even means within the framework of a study.
I see that Kathleen has got her hand up. Kathleen, would it be okay, and you can disagree with this, you can say it's not okay, but my inclination is to keep moving along, and then we have room at the end for your question. Is that all right?
That's fine with me. Your thing.
Thanks, appreciate it. So Joe gave us a really nice on-ramp for our second theme, our second subtopic on collaborative research. And we've seen this a lot in the other presentations, and we really wanted to focus on this as one of our core values. And this is to develop and sustain, not just develop, but sustain collaborative, community-based partnerships across the research spectrum. This was really important and we spent a lot of time talking about this. It's not just at any one phase, like, oh, how should we go about doing this study? Or how should we go about recruiting patients for this study? But it really starts at the beginning from setting the priority. What are the priorities that need to be investigated, need to be interrogated? It goes from priority setting to study design, analysis and interpretation, to implementation and evaluation. So you see across our respective research sandboxes, we see collaborative research being done at some, but usually not all of these levels. Speaking from my own experience, I tend to be a little less attentive to the bookends, the priority setting and the implementation and evaluation part. So that's something that my group could do better on. And these partnerships are multidisciplinary. They include scientists, clinicians, people with lived experience, and other community members, nonprofit agencies, local allies, and leaders, with a particular focus on under-resourced areas. So why this particular focus on under-resourced areas? Because oftentimes it's members from these communities who have less ability to make their voices heard. People tend to not go after them and say, hey, we want you to have a seat at the table. And so we need to be really explicit in engaging members of these communities. Jeff, Joe, anything that you'd like to add here?
No, we just got a very scary time's up. But one of the things that we had talked about too that I think is important is if we can focus on under-resourced areas too, if we can solve for those under-resourced areas, it's much easier to scale to areas that have more resources than the other way around.
Absolutely. And I just want to add, seeing Dave's presentation earlier is on the first bullet is dissemination. I mean, because in getting the word out, whether it's in scientific presentations or community presentations. So, you know, having that partnership all the way through from priority setting to disseminating to the community at large.
Yeah, great point. Joe and Dave both have an impressive CV that I think a lot of scholars would envy. And we see this notion of collaborative research in the very HEAL initiative. So I took a screenshot of the HEAL website, and if you click on the resources tab, they have a drop-down menu of patient and community engagement resources that we can think about to make those specific to our subgroup's focus on optimization. We also see this in Joe's collaborative work with the Entrust PE framework. I know this is really hard to see, but I have hopefully made it easier. They have a value embedded in this framework of patient and public engagement. And then they give voice to what are behaviors that are aligned with that value. It's not just that we find this important, but this is how our behaviors will reflect these values. And so in this case, it's embedding patients and public involvement and engagement throughout the research process. Our third value was an integrative perspective. And here it's prioritizing the integration of self-management, non-pharmacological and/or medication-based approaches to improving pain care and patient-reported outcomes. And this is a HEAL-funded group, the Empower study, integrative management of chronic pain and OUD for whole recovery. I just selected as a HEAL initiative that's relevant to this because you see that it's all about integrated management. I will pause there again, allow Jeff and/or Joe to chime in with additional comments on our third value.
When you look at the integrative perspective, I guess one of the aspects, and I saw some of the CBT presentations today or discussions, is music-based interventions. And just to note that Adam and I are respectively funded by two different networks looking for music-based interventions for pain relief and look at the mechanistic underpinnings of that. So again, I think the idea that some integrative approaches, CBT has been well studied, acupuncture well studied, music-based interventions have not as been well studied. So again, maybe even highlighting interventions that are really well accessed by a lot of different people, but not as well studied. So again, maybe even highlighting in that integrative approach, a music-based intervention example.
Joe, would you like to add anything or no?
No, I'm good.
Okay, cool. Yeah. So just to recap, we identified 3 cross-cutting values that we think are added value to these discussions on optimizing pain treatments. We focus on a long-term perspective, collaborative research, and an integrative perspective. And I just consolidated those here on probably a difficult to read slide, but I was committed to getting all the words onto one slide, and so I was not going back. But I will stop there and allow for, I think Kathleen had a question.
Yes, why don't we start with Kathleen?
I might have lost my question, but I was thinking about when you talk about long-term effects and management and I'm thinking about these conditions, and I think Joletta can probably jump in here too, is that long-term care and management is not always the same long-term treatment and management. It fluctuates over time. So you might be on some medication for 6 months and that might be managed and moved to something else, but you still have good care. And I'm wondering how you think about that. And I'm sure Joletta's been through all of this. We don't always expect you would have somebody on the same exact treatment for their life. You might expect it would change over their life if you're talking about super long-term stuff. So I'm wondering what you guys think about that and how that does that work into some of these other models that you talked about earlier. It's kind of complicated.
Yeah, Dr. Korish, you raised your hand. I'm not
Not sure
hearing
that the
anything.
attendees are able to speak up here.
They are not. I don't know if we can fix that for Dr. Korish, but I guess.
I can excuse me if you don't mind, I can pull him over as a
Okay, that would be, I think, valuable as the director of the NINDS. So I don't see any issues raised in the Q&A, and that worries me a bit because I can't imagine this group of 77 people doesn't have questions. I'm also not sure how to fix that.
we're working on the back.
All right.
Do you want to tackle the long-term perspective while waiting for the
Yes.
back end? I guess it's a great question, Kathleen. From our conversations, we really were, I guess, trying to reinforce that we were taking into account the length of time. You know, chronic pain is obviously a lifetime or too many decades of experience. And we were trying to encourage our evaluations, whether it's the treatment or just to evaluate the measure of the outcomes, to look at that longer term period. So I guess we weren't speaking to we want longer term treatments necessarily, but we want to make sure that we're managing or understanding the impact on patients or participants or collaborators, because we're using that term now, their quality of life over a long-term period of time. So it's more of that engagement with people over a longer period of time.
Yeah, and I would just add on to that, and I think Kathleen, you were gesturing at this in your comment, that optimization is not a one and done thing. It's not like you optimize and then it's optimized forever. It's an ongoing iterative process that requires constant feedback and revising and tweaking and maybe holding fast for a bit and then being open to having to optimize because things change. People's lives change, people's values and preferences change. So I think that we need to embed that into our research whenever we're thinking about how and what to optimize on.
No, that's all very good. The other thing that I think has just been made throughout this presentation today has been the need for a long-term perspective. And I was going to say this in the summary, but I'll just say it here since we seem to have time while we're waiting for some of the problems to be fixed. That long-term perspective, obviously involves the appropriate amount of time. In an acute, if you have your third molar extracted, the amount of time that you're expected to have pain is a day or maybe two. If you have a surgical procedure, it might be anything from a few days to weeks to months. And the issue then in just thinking about things that can happen over the course of a lifetime is obviously a much, much longer period. And I'm just interested in your thinking sort of about how you decide what's an appropriate period of time for these kinds of studies. And, you know, some of which I've already said, but I'm just looking at the long-term perspective, I think is key. And adding to what you just said, there's got to be adaptability as you go along. Things change, people change. They don't stay the same as they get older. Thoughts?
Absolutely. I mean, I think the key word in that first one is it's meaningful. It's twice meaningful change, and whether that's a clinical meaningful point, but it's meaningful to the participant or the individual, and over a meaningful time frame. So I think this is, depends on the study. I mean, you talked about the acute study with the third molar being extracted, or a longer term issue of other condition. So I think that's where the engagement of collaborative research comes in, because we might think meaningful of that third molar extraction is 1 or 2 days, but I'm not sure what the AE rate of those is, but it might be for participants. They want to be tracked a little bit longer just to make sure there's not an adverse event. So I think it's bringing that voice of the collaborative researcher or research participant or the engaged person into the mix to define meaningful for us or with us.
Yeah, I was going to say something similar, Jeff. And like, as someone who has had a number of surgeries, I can tell you that what I am told I'm going to experience doesn't often align with what I do experience. And where I find that alignment is within peer support groups. So I think that's we need more of that alignment between what is in the literature and those lived experiences, because they don't always jibe. And even just like the crafting of materials of what people are going to experience after surgery, doing that collaboratively with people who have undergone that surgery is really important, because it can address some of the concerns that people face when they're recovering, knowing if something is something they should be concerned about or not, and what might be concerning and what might be something that is going to go away in a few days, but not necessarily, because I've been told a lot, you're going to feel better in 2 days, and that doesn't often happen. What feel better means is going to be different from person to person. So having that more collaborative approach to both how we define things in terms of a research study, and then in that implementation phase or that dissemination phase, how we present that data to people is really important to be done collaboratively, so it makes sense to the people who are most impacted by pain.
Yeah, and there's a bit of tension in this. I mean, I don't think that it's unresolvable, but there is some tension that I think we should acknowledge whenever we're thinking about doing open science and pre-registering our trials and our research, is that we call our shots from the beginning, and it doesn't provide us much wiggle room from a very stringent perspective to adapt to changes in our participants' life and changes in their perspective. And, maybe I'm feeling a little bit better as a participant, and then that changes what I consider to be a meaningful outcome for me. And so I think that we just sitting and living within that tension is, I think, the only way we can deal with that. But I see Renee Manwaring has her hand up. I'll invite her to speak.
Sure. Renee, go ahead. And then there's some questions that we should get to in the chat, in the questions and answer, which looks like it's working again if folks have been holding off. Go ahead, Renee.
Yeah, so I'm amazed as somebody who submits grants, how often the reviewers tell me that this is how it should be done, and that you can't possibly collect it for that long because it's too burdensome on the individuals when you've engaged the individuals. And it may certainly be that I haven't communicated that well to the reviewers, but where they will say, no, everybody is treated like this, or everybody is only for this. And I go, have you really asked them? And I love that Joletta said she's told you'll feel better in 2 days. But what does that mean? And does she really feel better in 2 days? Does that really mean that in your practice, we call you at day 2 and we either have you come in because you're not better, or most people say they're fine? And then do we unfortunately extrapolate that and say that's the limitations to science, and therefore we're not going to look any better? So how do we make that more pragmatic and open ourselves up to those experiences?
Yeah, very good point. Adam or Jeff, you have a comment, or else we can go to some of the questions.
I completely agree. I do a lot of grant review, and it's really challenging to have someone be putting forth a really patient-centric approach, and the individuals in the room may not have that perspective and just are only looking for the practicalities of what they've experienced and their inability. So that you've engaged with your participants or future participants and said they want a longer follow-up is really frustrating. So I hear your pain, and I think it's all about, changing the FOAs. So it's really in there to include a longer term follow-up. So it can't be dispelled by the grant reviewers.
Lloyd, did we get Dr. Koresh in so he can say something, or shall we go to the questions?
Either he has to unmute or just or be.
He said he's not in position to comment openly right now.
Understood.
Okay, while we're letting that happen, it says from Ruth Chimenti, I appreciate the emphasis several speakers have placed on integrating physical therapy with strategies to enhance engagement and adherence. Consider the insightful comments about meeting individuals where they are from David White, which I think was really spot on. Ruth is interested in opinions on the potential role, benefits, and pitfalls of telehealth as a mode of delivery of interventions, and the implications for losing reimbursement and the whole issue of reimbursement. But let's not consider the cost at this point. Let's just think about whether it makes sense and perhaps try and integrate it at some point. Adam, Jeff, actually this is an open conversation. So Katie and Meryl, you commented on this as an applicable way of presenting or purveying healthcare for pain.
Sorry, I just hopped back on. Can you repeat the question, please?
I'm sorry, sure. The issue is on the benefits and pitfalls of telehealth or as a mode of delivery of interventions.
Yeah, so I think benefits, obviously, you could potentially reach more people that may not have access to in-person services, that are limited by high copays associated with in-person services, or limited by number of visits to a rehab provider, limited by their insurance company. So I think in terms of casting a wider net of people who have access to rehab providers through telehealth is a positive. One of the downsides, obviously, is you have to ensure that people have access to the internet. So for individuals or groups of people that may not have consistent or reliable internet access, that's potentially a problem. Some rehab providers will also say one of the downfalls of remote or solely seeing patients virtually is the inability to place their hands on them in terms of assessing how a patient moves or how well they're moving, manual therapy as a form of providing treatment. And I think that's one of the things for rehab providers, for physical therapists in particular, one of the things that sets us apart from other providers is the expectation that we touch our patients, and there is tremendous value in that touch. And are we losing that through telehealth or virtual services? So I think those are just some of the pros and cons to consider about telehealth.
Great, thank you, Katie. From Jennifer De La Rosa, a question that thinks about whether and how we decide how long therapy needs to be administered, and asks whether it could help us identify understanding how we measure intermediate endpoints, because nobody gets better completely over a single day or a single treatment. How could we measure intermediate endpoints, and whether ongoing low intensity maintenance interventions need or warranted to maintain such changes? And obviously what jumps to mind there is lifelong exercise, right? And the need for that, at least evidence seems to to support that. So Adam or Jeff?
Yeah, I'll just chime in to say yes, what what Jennifer wrote, that resonates. I like that line of thinking. I really like this notion of focusing on mechanisms. A mechanism is an outcome, and an outcome is a mechanism, depending upon where in the causal chain you're looking. And so I think oftentimes we power on our identified quote unquote endpoint, but maybe we should spend a bit more time about long-term engagement in the mechanisms that are presumably driving that endpoint. So I'll just that was really just a different way of stating what you wrote, and I just wanted to highlight that and say yes, I agree.
Mm-hmm.
I'd love to. Go ahead.
Go ahead, please. Go, Joe, please.
I was just going to say too, I think it's important too, like maybe for some more mixed methods research too, where if we have these intermediate endpoints or we highlight what endpoints we think are important, actually talking to the participants of research to learn from them what they think actually helped or didn't help in that process. Because I think we make a lot of assumptions about if we did an exercise intervention, it was the exercises they did that led to the outcome, when it could be something different. It could be that they were in a group exercise program, so there was a social aspect to it, or that they just really had a good, meaningful relationship with their therapist. It could be a lot of different things that contribute to them feeling better at whatever endpoint is determined, and learning that from them can inform better research moving forward too, because maybe we could even distill it down to even simpler interventions or simpler things to focus on in the treatment environment that could lead to meaningful outcomes for people that aren't specific to what we assume is what is working.
Mm-hmm. Jeff, and then Jen.
I was just going to say the second part of the question too about, is there a way to optimize low intensity maintenance interventions? And again, having those mediators or the intermediate endpoints would allow us to maybe give less of a dose, but keep maintaining that. So I love that second part of the comment too. So Jennifer, you were spot on. Thank you.
Jennifer?
So I'm not sure if this completely fits in, but I want to take a time to put a plug in for the idea of using personalized outcomes. So I think that in the long term, especially, and even in the short term, but in the long term, figuring out what people want from their care, and then making potentially, I'm trying to come up with methods of ways that we can incorporate personalized outcomes so not everyone has to have the same outcome. And so it's not about like engaging, 4 people with lived experience to even 20 people with lived experience and trying to figure out overall what do they want, but letting people choose at the beginning and putting the outcomes on the same scale so that you can use it as one outcome. And there are lots of complications with this, especially if you're trying to get a drug approved. What does it actually help? But I think that we should be thinking about this as a method. I'm trying to make it happen. So if anyone else wants to make it happen with me, let me know. Okay, that's it.
Great. Any other comments on that? All right, there's a question and statement from Beth Darnell, who makes a very good point that engaging patients in long-term effectiveness research has unique challenge. PCORI is making attempts to keep people in studies for up to 3 years, and that keeping them engaged is really problematic. In addition to which, long-term studies are confounded by the new treatments that patients get, the diseases they get, issues related to aging, and new issues that can occur over following up time frame. Beth, I couldn't agree more that we would hope to see NIH fund these types of studies, but I wonder what the panel thinks about how we might approach large-scale studies, and whether this might be an opportunity for what's generally called the learning health system, using data that's already collected every day on our patients in a way to study them over a long term. Jeff, I see you unmuted.
Yeah. I almost mentioned earlier when I mentioned music-based interventions, I was going to mention practice-based research, because I think it's really an efficient way to, as a complement to the SMART trials or the factorial trials, is really using the electronic health record. A lot of my research is electronic health record research, because even with, at the end of the day, patients don't have the opportunity, once the trials are over and we're in the real world, they don't have the opportunity to engage with the intervention the way we have them in trials. So I think using, as you mentioned, a learning health system is a brilliant way to move forward. So I fully support that.
Other comments from folks?
I have one
so-
comment.
Oh,
Sorry,
yeah,
Joe.
please, go ahead.
Use of research registries is another, I think, route, and maybe that's just saying kind of the same thing you were saying in a different way, Jeff. But one barrier to that is collection of high quality data, and that encompasses all the many facets of chronic pain and treatment response, in a systematic and kind of quick way. And so one thing that we've been using, and I think actually, Dr. Darnell is obviously very familiar with, is, the Quire system, and sort of using different ways to streamline, promise measures and collection of those. And so that's one way that I would see a way forward potentially in using sort of these learning health systems, potentially at a scale where you wouldn't have to do very large and complicated SMART trials, which may have diminishing returns in terms of clinical applicability. Like, would patients really be doing all these different adaptations to the trial or not? And in that way, it may be more fruitful.
Great. Let me add to that there's this concept of what's been known for years and years and years of N of 1 trials. And one of the things that's always struck me is that, in fact, that's exactly what we do with patients. Patient comes in, I make as good a diagnosis as I can. I start them on the therapy that is most likely to help a largest number of people with the least number of side effects. And then even with the best therapies we have, they don't work in more than 60%. And very often it's 30 to 40% of patients. So I know in my mind that we're very likely going to have to move to something else. And that's not formalized, obviously, but it is a way of testing treatments within patients. And, some of my colleagues say, yeah, okay, but the last time they came in, they were very depressed. And that's why the medicine didn't work. And now they're not so depressed. And so the new medicine works better. And yes, I get it. It's complicated. But it occurs to me that we could maybe come up with a methodology that allows sort of a documentation. And this is really a documentation issue in the health record of what's tried, how long, what the side effects are in some way. And patients very often are more than happy to tell us about that. And Joletta or Dave, I'd be interested in your thoughts about the willingness of patients to collaborate in really understanding what works for them. But the thought occurs to me that we ought to be able to come up with some methods to incorporate some of this without making it tremendously burdensome on the clinician. That's clearly not going to happen. But if we could collect a more robust data set, we'd have a better chance at understanding some of these things. Joletta?
Yeah, well, I think that in terms of the willingness for that, there are a lot of people that are willing, but it's also dependent on where people are at, and like Dave said, meeting people where they are. And I think that, I know I keep beating the same drum, but the more collaborative approaches we take, even into the approach of how we collaborate with patients, because my opinion alone is not the opinion of all people with lived experience. So I think having more collaborative approaches from the start, even in determining how we get to that stage of finding those willing partners and what that looks like, is important. I don't know if I answered the question, but.
Well, I think you did. I mean, I think the point is to try and get people to work with you. Katie, I see your hands up, and then Jeff.
Yeah, thanks. I was just going to touch on, because there was some discussion about, long-term support, but maybe for self-management, maybe low intensity care. And I think that actually, we talk a lot about telehealth being an option for people who can't access care, or that there's barriers that they can't come in, or transportation. But also, I think that can be a really good opportunity for, more low intensity or sustained care using that telehealth model. So that was just something that I was thinking of as well.
Great. Jeff?
Yeah, John, based on what you were just saying, I have a lot of conversations with clinicians. I'm a research psychologist, so no clinical skills. But this idea of guidelines, and if you look at the guidelines for acute and subacute pain, low back pain in particular, they'll talk about PT and acupuncture massage are first-line treatments, but there's nothing about dosing, when to do it, when's the failure rate. So all this is not actionable. So I think this idea of using electronic health records, Bennett was saying, and trying to finalize or finesse that to be understand really what's happening with the participants and individuals are working with us, I think is really important. Because I know my providers who work in my clinic just keep saying, this is great, we've got these guidelines, but I can't do anything with it. I've got to be going through all the papers all the time to know what's next. And it's not possible.
So we need to sort of create a functional order set, right? That says, okay, click physical therapy. All right, go do this for 3 weeks, do this, blah, 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 blah.
Exactly.
Okay.
Exactly.
Excellent. Excellent point. Other points on that question? While people are thinking, the one other aspect that we didn't mention is the use of texting. And at least here at the University of Pennsylvania, we've had a very effective post-operative texting program that has allowed patients to respond and say how you're doing. A key feature of that is that when you push the thing that says, I need to talk to somebody, you don't end up on the phone waiting for, an hour, or you don't get a AI voice that says, I can help you with this. It clearly needs to be linked to somebody. And so it's not a inexpensive way to take care of patients, but it is a way of just reaching out to them and saying, is there anything we can do to help? And then and encourage, providing useful information about things they might do or other things. But if they say, no, I really need to talk to somebody, they get to talk to somebody at least within a reasonable time frame. Katie?
Yeah, I just wanted to touch on what Jeff had said about, moving forward with different interventions and the recommendations and what am I supposed to do with this? I definitely agree. And I think something that I'll just bring up, I think we put in our parking lot because we thought maybe it had too much overlap with the training and the workforce focus group and we're focused on the intervention delivery. Our optimization, but I think, something that several of us, I think, were saying is that providers need to be educated to be able to deliver those interventions or even refer out for those interventions. And what I see more often than not too is that, we're all here, the clinicians here have like a strong focus in pain, right? We either treat pain or we research pain, but not every provider does that. And so I think at times, like you might go to a physical therapist who's like, I'm not really sure what to do with, XYZ. You should really go see a different physical therapist or you should go see a different provider. And I think that happens in primary care, that happens with nursing, that happens with occupational therapy. I mean, if you go to a GI specialist, they may send you to a pain management doctor instead, but so I think sometimes there's this idea that like pain should be treated by somebody else. And it's not necessarily the case. It's just they aren't like that provider individually doesn't feel qualified or trained to deliver the intervention and maybe doesn't even know where to refer patients to. And that's a huge problem as well. So we talked about that as part of optimizing the intervention delivery, that providers have to be educated as well.
Yeah, I mean, that's a very important issue that actually we did not really touch on today is the whole spectrum of helping empower the majority of caregivers to feel comfortable at least talking about and perhaps understanding some of the initial steps and what to be done for these kinds of things to use what we already have. No, I think that's a very key issue. Go ahead. And then Joletta will come to you.
Sorry, Joletta, if I could just say also not just like what I learned outside of PT school, right? So, because the research continues to develop and like things continue to come down like from all the evidence-based practice and recommendations. So there has to be a way for providers to continually be educated on these different factors.
Yeah, no, that's a very good point. Joletta?
Yeah, I was just going to second that too, and challenges in other areas too. Sometimes they're the only provider that you have. And so like the providers here can't just refer you to someone else because they're the only one. They're literally the only one in the rural area that I live in. If they refer you to someone else, it's going to be a 3-hour drive. So being able to work with the clinicians that we have, because they're wonderful people, on pain and what they can do for pain for members of our community would be amazing for that workforce to be built up and empowered to feel more competent and confident in treating pain patients rather than having to send them out of the county to see somebody else.
Yes, and just to say that as was presented, I think, by Jennifer Ravitz, the overlap between the various committees that are considering the various components of the strategic planning process that are considering these things. One of them is implementation. And in our conversations with the implementation group, we decided we're not going to discuss in this group how to actually implement some of this. And what you're raising are very, very important. They do fall in that category. But I certainly will take on the process of making sure that that gets integrated into the system somehow. Jeff?
Yes, there's a current thread about using large EHR data sets with well-curated pain assessments and outcomes to interrogate what works for whom. And again, and then Ray pointed out, these data sets are interrogated or dependent on providers who document. I've run one study where it was 17 integrated medicine clinics where we had a pretty good way of documenting what the patients have received, and then long-term outcomes using promise measures. So it can be done, and we're building that now into Epic. So I think that's the strategy of trying to use some of this real world data to help to engage learning to help providers and patients know what can work for whom well, at what time and what cadence of intervention. So that's we're trying to do that.
One quick thing, and then which is that the other aspect of that is mind-body interventions come in a variety of different flavors. And, my truck driver might not like to do yoga, at least not driving down the highway, I hope. Whereas somebody else might find Tai Chi better or whatever. And it would be very interesting, I think, to understand that priorities of patients is key in the conversation between patient and physician about what's going to work for them in their lives and what can they be. What can they do on a regular basis, and what's going to keep them engaged, I think, is a key component. Meryl?
Yeah, I think the other point to that is, we've talked a lot today about just, going back to physical therapy, but physical therapy is a profession. It's not an intervention. And so if you think about the myriad of treatments that a physical therapist can provide, typically those treatments are not necessarily specifically parsed out or targeted in trials. And so just being mindful about what it is why we select a treatment that we select, or why we specifically study a treatment and what particular mechanism that treatment is targeting, I think is also something that we need to consider with our research.
Yes, no, I agree with you completely. And yes. These are practitioners who decide about particular therapies. And actually, you raise a really important point, which is that certain approaches to physical therapy might be the best for one patient, but not for another. And the same physical therapist might not be able to do both. And so, there hopefully is flexibility enough in the profession to be able to say, George, we're clearly not getting where we need to go. Maybe you should go work with somebody else who has a different approach. And, the same thing happens in the care of patients, which is, we're just not hitting it off here. Let's find you somebody else that you can get along better with. Adam?
Yeah, I was just going to double down on a couple of comments that were made. And I think there was some chat about this as well, about trying to help find the treatments that the patients find most useful, most engaging, most fitting with their lifestyle. And so we have a study in our Urban Safety Net hospital here. It's an RCT using a decision aid for that. And so we have individual coaches that engage these really hard-pressed participants, people who have a lot of life burdens on top of pain burdens as well. And so we engage them over the phone with a decision aid about what do you want most out of your pain care. Not only that, but then, okay, here are some evidence-based options that your healthcare facility has available that you can access. Which of these sound appealing to you? And so a lot of it is education. This is what CBT can actually do. This is what exercise or massage or whatever. And then it's how do these fit into your life? So for some people, I think Joletta had mentioned that it's not necessarily the exercise, it's the fact that you're exercising with other people. And so we asked them on this decision aid, do you want to, is it important for you to engage in a treatment by yourself that's flexible on your own time frame versus something that's scheduled with other people? And so walking them through that in a decision aid process can be really low-hanging fruit. Doesn't take a lot of any technical sophistication really. But then sometimes patients need help communicating that to their doctors. So they've done all this pre-work, but they get to the clinic setting and they're just overwhelmed by the hierarchical differences, the language differences, just the power differences. And so we're also pairing that decision aid with some patient empowerment and skills training to help patients feel empowered that they can actually engage with their doctor as an equal or whomever their healthcare provider is. And so some of these things are relatively, I mean, this isn't new stuff. It's just combining it to optimize for the people that are living with pain now and the location they're living. And then you can layer on top of that some more technically sophisticated prediction models that I think Susmita was referencing in one of her comments. But it doesn't have to be that fancy or that sophisticated. There's some really near-term things that we can engage with. And so I just wanted to emphasize a couple of those themes.
Okay. Great. We've been addressing different questions from the others on the call, and I don't see any new questions here that have not been answered. Well, actually, Adam, did you address Sarah's question about multiple pain management strategies like toolkits where patients could try out different options and create their own what works best? It sounds like that's exactly what we were just
actually
talking
I should
about.
have made more specific reference to Sarah's comment. But, toolkit. I mean, our decision aid in a way functions as a toolkit, but I suspect that there are other ways that Sarah or others have envisioned a toolkit. A decision aid is relatively straightforward, but it's not the only way that we can envision or optimize a toolkit.
Okay.
And if other folks have comments about that.
Ben?
I have a sort of a related but unrelated comment. I think it sort of segues well into the the idea of decision aids. But one thing that we've been talking a lot about, or sort of what I as a sort of physician would call maybe relatively lower risk interventions for pain. And what hasn't been talked so much about is surgery for pain, which is a pretty high risk endeavor. As an anesthesiologist, I sort of think about it that way anyway. And so I think one thing to maybe consider among the panelists, I don't know if this, how we would sort of treat optimizing the integration of surgical methods for pain, specifically thinking about arthroplasty, lumbar surgery for chronic low back pain, typically done by surgeons who may not be as interested in pain as an outcome as much, even though it's for pain. So that's sort of my thought. Things that we should probably think about, in the next 5 years.
Great. Jasmine Butler put into the chat that most practicing physicians are strongly encouraged not to use a lot of opioid, and where she where she currently is, and I apologize if I'm getting that wrong. There is significant under treatment because doctors are actually paid to not use opioids even in severe pain, and so I guess she's asking the question about whether there are ways to think about the appropriate use of opioids. I mean, one of the issues about optimizing care is, and probably should be, the appropriate use of opioids. That's obviously a very large topic, and there is a separate group in the strategic planning process that's looking at the intersection of substance abuse and pain care that will also consider this issue. But I don't know if any of you wanted to jump in on that.
I'll just say, like, I'm not a physician or, so I'm not prescribing opioids or making decisions on that. What I will say is that I do think that if for any provider to, whether it's a physical therapist or a physician or another provider, if you say, well, we can't do this for you, but we can't offer you something else, that is a huge, I mean, I'm sure Joletta and Dave are the better people to like ask how that feels as a patient, to say, well, we're going to take away this intervention but we don't have anything else. So I think that's where my comments about making sure that providers are educated on different options for interventions is really important, and that providers need to be able to access the referral sources for other interventions.
Your comment on other interventions leads into the next comment by Joanna Starles, who basically says that in considering post-surgical care, things like spinal cord stimulators, nerve blocks, lumbar fusion injections, etc. Not about acute care, acute operative procedures, but about acute care of patients and acute treatment of chronic patients as well. And the evidence for them is somewhat limited, and clearly the evidence for in whom it's going to work is somewhat limited, and that we ought to think about trying to advance that. And it occurs to me that we as a group have not thought at all really about how to include specifically devices in this process. And as we all know, the approval process for devices is very different. And while it's hard to do clinical trials, especially blinded clinical trials, one can argue that we really need to do some of those and try and figure them out. So let me just open that to see if anybody else has something to say about that. Ben, I see you agreed 100% with, but
Yeah,
we'll let, go ahead.
Just quickly, as someone who does some of these procedures, I think anecdotally, it seems to make sense potentially as a multimodal component to multimodal management. Now, what we don't have is really strong evidence for that. So I think that could be an area that needs to be emphasized. In what situations could a nerve block or a spinal cord stimulator be most helpful for a patient, or least harmful, and guiding some of those decision-making processes, not just on avoidance of harms, like, many surgeons would only say you're a candidate for surgery for knee replacement if you have a certain BMI or don't smoke. But how about sort of a likelihood of success of knee replacement as informing, treatment decision-making?
Good point, Renee.
Yeah, I fully understand where Jasmine is coming from. One of the reasons I brought up my daughter was the fear that, as people have said, children don't need opioids for surgery. Will we go back to 39 years ago where we didn't give opioids and anesthetics or anything for children's pain because, they're resilient and they'll just get past it? I'm concerned also that we've made judgment calls that I hear from my elderly parents and in-laws about their friends being in horrible pain and then having to wait 6 weeks for an injection that may or may not work because that's what is willing to pay for. And oh my gosh, if they get opioids at 80 years of old age, they might die, or they might get an opioid use disorder. Really, what are the risks when you're in your 80s, upper 80s, that you're going to suddenly have an opioid use disorder? So how do we get it at those pieces, I think, is really a challenge, because we really like this idea of everybody should fit in this box. And so kids shouldn't have opioids, adults should be able to hang in there for how long? And that's not consistent with the lived experience.
Yeah, I mean, you bring up something that is key here, and actually it melds nicely with something that's been put in the chat by Lindsay Oros. And, she comments that she works with a group of surgeons who are very thoughtful about how they approach things and use minimally invasive processes, and that we should be careful about trying to argue that people should never get surgical approaches to things that hurt, because clearly in some situations they work. And what that brings up in my mind, and this overlaps directly with the prediction group, is that we need to figure out how to understand who's more or less likely to get better from everything we do, be it medications we give, non-medical interventions and surgery. And one of the key areas that we have really not done a good job with is trying to understand that, because it is truly complicated, and I don't want to make it small. We're beginning now to look at genetics and epigenetic potential predictors, but it seems to me that's in a subjective syndrome like pain that's affected by so many biopsychosocial issues. It's going to be very hard to get a lot out of genetics. But clearly knowing whether somebody at heart is somebody like you were, Joletta, with a very positive attitude towards how to make things better, versus somebody where even the smallest hurt is not manageable. I mean, those are different people, and we should be able to help all of them to achieve the best lives possible. But it seems to me that we, and the reason we haven't talked a lot about prediction, although it's been mentioned in a lot of the comments people have made here, is because there's a whole nother group that's dealing with biomarkers and predictors. But clearly that's a major role, plays a major role here. And to your point, Renee, we need to know who's likely to get into trouble, number one, but also who's likely to respond to opioids, and what's likely to happen to those whom we give opioids. And we don't have a good way of knowing how to do that. Although I will admit that there are attempts to try and understand who's going to get into trouble, the SOAP and other things, which honestly don't do a great job. So it's clearly a huge issue with regards to the kinds of things we're doing. Renee, it looks like you want to say
if I
something.
can add, and I asked Dave if he could maybe comment on this. I was surprised when Dave said that as somebody on dialysis, there was a study looking at decreasing opioids. My father was on dialysis for almost 20 years, and NSAIDs were a no-no. So I think of what I have to treat somebody's pain. Well, if they can't have NSAIDs and they can't have opioids, that doesn't leave me a whole lot. What my dad did teach me was he would take gabapentin 100 milligrams every other day. And I said, gosh, Dad, that's really low. And every other day, until it hit me that, oh, wait, he doesn't urinate. His kidneys don't function. So I guess maybe a small dose of gabapentin works a really long time in somebody who has no kidney function. But certainly nobody prescribes it that way.
Yeah, I can't really speak to that, because I had an interesting perspective on treating pain in dialysis, and that I didn't talk about it a whole lot. I just dealt with it. That was just my approach. Now, in the years since, I've learned to acknowledge that taking things for pain is okay, but it took me a while to evolve to that. I think it's just part of the way that I grew up, and just not wanting to take anything for the pain. I think that actually runs in my family, because my mother is sort of that way too. She just won't. She won't even admit that she's in pain. So, I think this is something that we need to explore as well.
Yeah. So David, let me, before I let you off the hook here, let me ask you, one of the concepts that's come into being in the wake of the pain is the fifth vital sign and freedom from pain, freedom from quote unquote, which was, since I had something to do with that, at least here at the University of Pennsylvania, I can look back and say that was really not the right thing to do. So what we target now is tolerability. And one of the interesting things that you raise is what's tolerable for one person, what somebody can live with on one side is intolerable for another person. In addition to which, your mother, for instance, not admitting that she's in pain, or you're sort of wanting to tough it out and not being willing to take help, when hopefully the help that you ended up getting did improve your life. It raises a whole question of sort of what you think about the idea of pain tolerability. And let me just ask you that.
Well, I think, you know, we need to do what we're doing right now, which is talking about it. And that's something that, you know, wasn't really done in my clinic. I know when we were approached every day, we'd say, how's your pain level? And that's a good start. You know, people would simply say whether they were in pain or not. I did not, but that was pretty much it. If you were in pain, you got, I think it was Benadryl. And that was all that was allowed, to be honest, other than what people were prescribed on their own. But we never really had a conversation. People weren't really asked about, you know, their feelings about being treated for pain. And I think that needs to be looked into, sort of building conversation starters and just ways to get people to express what they're feeling, and then sort of using shared decision-making to figure out what's best for that person, rather than the one-size-fits-all treatment that a lot of us have to get used to.
Thank you. That's very helpful. Other issues here? So according to the schedule, we're supposed to be circling back to some of the priorities that people put into their presentations here. And what I'd like to do is to take, actually, and there's one question. I'm sorry, Stephanie, I didn't see your question there. Let me just go back to that for 1 minute. Just wanted to add that there's some overlap in the discussion with the intervention and the health system groups who will be addressing the issue of de-implementing ineffective or harmful interventions. And that may be a way to frame it too. Studies of these interventions may result in conclusions that they should be de-implemented. And I think an obvious example of that, albeit a rare example, is propoxamine, right? Which was prescribable and then became unprescribable because there was no question that it did zero for anybody and only caused side effects. Any thoughts from any of our panelists about the idea of de-implementing ineffective treatments?
I would say, you know, I think this could be a real novel way of implementing some of these smart designs. You know, I see clinically, I see a lot of patients on combinations of treatments like duloxetine, gabapentin, muscle relaxer, you know, tramadol, all of them at the same time, and they're still having a lot of pain. And so, you know, seeing how we could de-escalate or de-implement either novel methods, you know, maybe supported through multidisciplinary approaches like psychological or different types of other non-pharmacologic approaches, acupuncture, you know, these could be, you know, really powerful in helping minimize risks. And actually in the chat, there's a bit of a discussion sort of about, you know, that there are potential long risks of a lot of these therapies. And so, you know, de-implementing makes sense to explore.
Yeah, actually, I am going back and forth between the question and answer and chat, and I didn't see that. Is there something there you want to summarize for us, Ben, or?
Yeah, well, no, I think it's just that there's, you know, each medication class has pretty significant potential adverse events. And we need maybe more evidence, long-term evidence about harms with some of these, especially non-opioid medications. I think that was pointed out.
Yeah. So I will make a comment on that because I think there's some very key issues here. One of them is that there have been a couple of articles recently in some very prominent journals about the side effects of gabapentin and the potential use of gabapentin in elderly population where a fall can lead to a fractured rib or fractured hip or skull. And that clearly has a very high morbidity mortality in that population. And therefore, it obviously should be a last line treatment, if any. On the other hand, gabapentin in the right population can be remarkable. And while individual stories are just individual stories, a patient of mine who develops a post-chemotherapy induced real discomfort that got in the way of her life after breast cancer was cured. I mean, basically had none of it when gabapentin was added at a relatively low dose. And she was relatively young and didn't have the side effects. And, you know, we tried the N of 1, right? I tried to take her off and she got them back and we put her back on, et cetera, et cetera. So that raises the question of the following, which is that we have to be very careful how we decide something doesn't work. And what I mean by that is we could have a drug that cures pain in 5% of the population, let's say, very small. In order to do a clinical trial that actually finds those 5% who are cured would be very expensive, very large, and no drug company is going to take it on. And yet we would bypass getting rid of pain for 5% of the population. I'm not saying we have drugs like that, but the fact that something only works in 5% of the population doesn't mean it's not important to have in your armamentarium. It means you need to be thoughtful about how you apply it. And we can take a lesson from oncology, which is rapidly moving to the stage where it's not the cancer you have, it's the genetics of that cancer and what immunotherapies are there that attack that. I'm struck by the fact that Keytruda is now indicated for 19, count them 19 different tumors. And I think if we could get to a point where we could accurately diagnose what's going on in pain patients, we're a long way from that. So that we could then primarily target therapy in the same with the same accuracy that we're doing in oncology, that we would be very helpful. We're clearly not there yet. But so I think we do have to be very careful to say, okay, this only works in 20% of patients, so we should never give it. Now, if it has serious side effects, and there needs to be a risk-benefit issue, but we need to be careful about how we throw things away if they do work dramatically in some percent of our population. Renee, you're unmuted. Does that mean you wanted to say something?
No, I just got to repeat. I'm worried when we de-emphasize that if it works for somebody, we then get rid of it for that person. And we definitely saw this with our patients who were well managed on opioids chronically, that suddenly they were reduced and removed. And with an aging healthcare workforce, then nobody would pick them up. And what did we do to those patients because of this random? This is how many MMEs. And so, while perhaps, and I so appreciate Jocelyn's comments in the chat, because I don't know if she would have been as big a fan about lymphatic massage and lymph drainage massage if she had stayed on her opioids. Is that why she found something else? But it's incredibly hard to say to somebody, well, because somebody else had a side effect, we're going to take you off this forever and find something else, especially if they've had chronic, really debilitating pain and are doing well.
Yeah, and that was the same comment you were making about opioids, which is that, there clearly are people who need them and benefit from them, but you have to really take into account all of the issues that go into it. And then there's the societal issues that are involved in that process as well. Let's see what else is there. I think the last thing was by Jocelyn talking about her, the situation you just mentioned, Renee. Okay, what I'm going to do now is just briefly share my screen and briefly review some of the stated priorities, and just to review them briefly to remind people and hope that there are other thoughts about that. And then as a final part of this, I'm going to try and summarize sort of what I've heard and try and condense it into the most important things. And I will admit up front that there are issues that I will forget. So please do not hesitate to jump in here. All right, so the enhancing care delivery, and I've underlined some things here, at least of the first ones, but advanced trial designs to determine optimal combinations or sequencing of therapies. I think we've talked a little bit about that. Pragmatic research initiatives, implementing care delivery models, and identifying barriers and facilitators to access, and especially the access for underserved populations. It's one of the things we have not talked about here, which is the fact that if we, many of us probably live in cities or at least in large towns, and access to care is relatively easy. Violetta, and what you presented, you talked about needing to go 3 or 4 hours to get, or an hour and a half or whatever, to get what was thought to be care that you needed, and how hard that can be. And so the implementation group is considering, not our group, but the implementation group is thinking a lot about how to do that. And in light of serving the underserved population, then clearly the models of telehealth and hybrid care are interesting, and I would add texting to that. And then personalized pain management priorities. And folks, if you have additional things to say about this in the panel, please just wait a second and raise your hand. And if you're in the participant group, then please type into the question and answers or into the chat. Personalized medicine, and you can see I ran out of time to underline things, but personalized pain management priorities, integrative biology, psychology, functional social determinants, and one can add some other things here. Create flexible, feasible, and meaningful assessment of frameworks. And support methodologic studies and mixed methods research, which I think is a key issue in terms of thinking about additional study designs, because clearly we need to talk to people. We've all agreed to that. We agree with the importance of including patients with lived experience in our research, but we also need to go out and be broader than just the people who volunteer and are capable of doing this with us. But we need to understand what's important to patients for a variety of reasons, and then test culturally appropriate personalized interventions. And that clearly is an important issue that also is being looked at by the implementation group, which is the idea of cultural differences in how people accept and deal with therapies, how they describe their pain, what's worse for them. And that speaks also to the need for personalization and the ability to adapt what we do to the people we're taking care of. There's the prevention across the lifespan with the emphasis on lifespan. And the real issue here is in developing interventions, coping skills, resilience for both patients and caregivers, system level neuroscience education to help people to understand what causes pain and help them perhaps to deal with it better. And then to look at what we could do early in life to potentially prevent those things becoming important later. And the effectiveness of strategies targeting the risk factors and early interventions, especially in high-risk groups. And those include a variety of things that are listed here: rehab, psychology, pharmacology, et cetera. I'm not going to go through all this. But, to meld with education, any expert in education will tell you that if you completely remove exercise from kids' day, they don't learn as well. Never mind that they get more pain. And then the sleep deficiency, which is clearly one of the manifestations of having pain and can be really detrimental over the course of the lifetime. Treatment conditions and adaptation, advanced evidence to identify optimal combinations of therapy, new therapies that we have used for other things and that might work in pain, and then development of self-management programs tailored for the diverse population. In other words, understanding which things are going to work in which people and, across a broad range of things. Identify methods to optimize patient engagement, a clear issue. And this means engagement in our research for sure. But what we're really talking about is engagement in the therapy. And to Jennifer Gawanter's point, maybe coming up with measurements that are important to the patients and figuring out what's important to the patient and trying to treat them best for that, as well as to study it that way. And then patient-centered treatment planning methods for multimodal care, and exploring the potential for repurposing clinically available therapies. In the cross-cutting values, there were issues about long-term perspective, and we talked a little bit at least about how long is long, and it clearly differs depending on what your study. But that there was an important mention about the fact that we need to have some sense as to whether people are starting to get there, right? And they don't have to achieve complete relief in a very short period of time, but we need to know if they're at least starting to get there. And then we talked a bit about how that is can be encouraging in terms of getting them long-term lower level treatments to try and maintain that progression. Collaborative research, obviously we need to look across the spectrum and to implement a whole host of things. I commented that one of the things we sort of are missing in all of this is interventions that are come from devices, but obviously in terms of looking at what we've got, devices play a role there. It is very clear that we don't really understand enough about the devices that we use. There is probably better data about spinal cord stimulators because what's done is they're turned off or given very low level stimulation versus what's considered appropriate stimulation. And those kinds of studies do show some benefit. Things like acupuncture, whether it's the acupuncture process versus inserting the needle, and is there a placebo for it? And then integrating the perspective, prior integration of self-management, non-pharmacologic approaches. So I'm going to stop there and see whether that stimulated any questions or thoughts on any of our panel or those online.
John, it's Jeff.
Yes, please.
I thought we had a good conversation about the learning health systems and modifying or using the electronic health record to understand the real world. What are some of the options that work for people and don't work for people, having some structured ways to understand that without being so burdensome. But so the way to kind of include that as a potential, maybe in the cross-cutting, just because it could serve across a number of those. But something that came up today, I thought that was really important to not miss.
Yes, absolutely. And just to be clear, these are the priorities that were put in place by the speakers that we've had. And we've been taking notes and we've been going along. And I think that your point is very well taken. In fact, I have written down sort of a slightly different approach to those summaries, which I guess I can show. But, please, others, comments and thoughts? Again, I don't know if there's something in the chat that I'm not seeing. No, well, let's see. Jennifer, were you next? As one of the few sociologists in the research of pain, I'd like to offer that the social aspects of pain are measurable and impactful, not only in the most macro levels, usually, but also in the meso and micro level. I agree with that completely, and that we need to take those into account. The question of how to take them into account, I think, is not as well described. I mean, we know they're important, and we know that people who have clear psychosocial issues don't do as well. And, the idea of building people's social networks, I think, is a key issue as well. The one caveat to that is that obviously there needs to be some thought about what it means to overly emphasize people's pain and constantly offer to do things when what they really need to do is to get up out of the chair and walk a little bit, even though they're backwards. So I think it's a very interesting comment. Adam?
Yeah, I just wanted to follow up on Jennifer's comment. It's a really important comment. We talk about optimizing pain treatments as if these exist. You know, they're atomized. People are somehow divorced from their social networks. And so we might think about, if we're going to optimize treatment, we might think about that specifically to their social environments and not just as an individual person somehow living on an island. We can think of optimizing the treatment for their social support network or lack thereof, and then also optimizing the social environment, their support network, to meet or to synergize with the treatments that the patient is most well suited for. So I just wanted to say thank you, Jennifer, for bringing that to our attention. I don't think that that has gotten enough of our attention in this conversation or in other conversations. And to the extent to which it does, it's somehow mashed together with the psycho. So it's psychosocial, as if those are just one thing. So thank you.
So John, I want to make sure in prevention across lifespan that maybe it's number 2, that where this fits. I think in the pre-conversations I had said that the average age of a nurse in our healthcare system in the United States is 52, and 20% are over the age of 65. And we know that nurses used to, the number 1 reason was because of chronic back pain that they left. It's now burnout. I think chronic back pain's maybe 2. And yet, and maybe it fits with that social, we're not using lift equipment that is available. You know, we're still expecting it.
Interesting.
Expecting us to, you know, just come on in and try and get the youngest person. And if you have a male nurse, then they absolutely should come in and lift that bigger patient. So does that fit with prevention and some of the prevention across the lifespan?
Yeah, no, I love that. I you know, and please continue to send in these comments, even if you think of them after we're done here, because I think the whole idea of getting at prevention, and where is it here? Anyway, is the need, I haven't finished it yet, the need to include the, you know, our own care and, you know, not trying to lift up the box, you know, the 70-pound box of wine from your doorstep. But, you know, as you point out, the need for, you know, job related, you know, emphasis on, I can't spell here, but on, you know, being thoughtful about trying to prevent back pain, which is the most common disorder in healthcare workers. Yeah. Other thoughts?
I'd like to
And-
piggyback on that if I could.
Sure, please.
Just in terms of collaborative approaches to designing those as well. As a firefighter, we had a lot of programs, injury prevention programs, but they didn't have a lot of buy-in from the guys on the floor because they weren't designed with the people that the prevention programs were targeting, and often didn't address what our actual concerns were. And like Renee said, a lot of that had to deal with lifting patients. Like we'd be taught certain ways to lift patients, but then when you're responding on a call and that patient is between the tub and the toilet, all of that goes out the window. So having more collaborative approaches to prevention in those workplaces with the people in those workplaces is really important, because a lot of things can come down that aren't relevant if they're not designed with the people that they're designed to affect.
Yeah, no, I agree. And I just added it here specifically. So we've got about 10 minutes and the are opening it to other questions or discussion points. We've been at this now for almost 4 hours. So I would understand if folks have gotten a little tired of talking, but you know, if there were things, I won't claim to have been able to summarize everything here, but it's what I was talking about before. Jeff, you'll notice that I put in, excuse me, where'd it go? All right, I won't point it out, but for sure, health system, yeah, you're learning health system and registries for learning things. Clearly an important issue to include. So other thoughts? Okay, I'm gonna stop sharing. Oh, go ahead. please.
Sorry. I was just gonna say, I didn't see maybe the word multimodal or combinatorial intervention, so I think that might be just something important to emphasize along with the multidisciplinary. So, because I think there's many, I think there's a lot of us who would
Yes,
agree
okay.
that it's not a single thing that's going to, be needed as an intervention.
Yes, and you're absolutely right. What I meant was multimodal, and what it came out was multidisciplinary. It
Although
should be
I think multimodal and multidisciplinary, I mean, I think you could do both of those for
they
sure.
both- well, absolutely, they both need to be there. I completely agree. Okay, I'm not sharing anymore, but other aspects that folks thought of, and what our plan is, just to be clear to the panel members here, is we're going to put this together. Claudia and I are going to try our best to put this together in some sort of summary, and we're going to try and send it out to everybody. Depends a little bit when we can meet again. My assistant or the NIH is going to send out a doodle poll to everybody, and we'll see if we can meet either on a Monday or Wednesday, probably in 3 weeks, sort of just, before the week of Christmas. So it's not getting into people's holidays and kids and other things like that. And what we'd really like to do is to have another maybe 60 or 90-minute meeting just to make sure that the things we have on those lists make sense. We do need to try and consolidate these, and there's some clear overlap between a bunch of the things that are said. So I think we'll be able to do some of that, but we also do not want to miss important things. And so we'll try and get that all done. Ben, I see you have your hand up.
This would be, I think, just echoing maybe into a good cross-cutting theme would be using or promoting multidisciplinary teams of investigation, including, patient collaborators, but also people who don't usually do pain research. So what I'm thinking of would be like computer scientists who may be involved in like human-computer interface that could help patients, it could help, clinicians, maybe, engineers and occupational therapists who could work with the lifting teams. So I don't know if that, maybe it's not a content area for the future, but, highlighting, multidisciplinary groups of researchers who could tackle these cross-cutting questions could be helpful.
Yeah, I really like that. And I'll have to say, one of the real advances in the mechanisms of pain was an NIH conference that was held maybe 25 years ago, which brought together neuroscientists who had never thought about pain in their life, because the neurologists and neuroscientists don't like pain very much, or at least used to not. And pain management folks. And the cross link between those were amazing, leading to a real explosion of mechanistic and interest in how those things work. And I think that the idea of using expertise across a broad range of things to help us to learn how to better implement, understand, diagnose, et cetera, would make a great deal of sense. Great. All right, we are almost at the end here, and what I've gone through what everybody has said. Jocelyn, I'm not sure you're in the room. I'm not sure you're able to speak. You sort of limited.
Oh, hi. It looks like I'm able to talk. Is that okay, or?
That's fine. We have 4 minutes. I need
okay.
to say thank you to everybody. So if you can keep your comments short, that would be great.
Okay. I'm not exactly sure what I want to say. I thought the meeting didn't start until 12, so I was a little late arriving. I apologize for that. Pacific Standard Time, but I've been in medical practice for 40 years. And during that time, I've helped just everybody who comes to me gets better. My mom was a nurse with rheumatoid arthritis. I started by helping her. My husband with broken back, heard about medical massage, got into the program, graduated in 1985, realized through our physiology prof here in BC, Canada, it's been recognized for over 75 years. And our physiology prof said, we don't know how it works, even though he's a PhD. So I went on to become a researcher, started writing thesis papers, and realized I had the answer to pain. But in order to prove that, I needed to make something that could measure pain. So I could feel pain with my hands. I could fix pain with my hands. I wanted to make a device that could duplicate that palpation skills that took me many years to hone in on, being able to detect those finite inflammations where people felt pain and get that concurrence from them that they felt pain with pressure. And that's algometry, and then using thermography, galvanic skin response, and also sounds of crepitus in the tissue that my hands could feel when they ran over the speed bumps where the bubbles are, I call them, or patients feel pain. And I can dissolve them with my hands mechanically, and people get better, including professional athletes. So that is hard. It's hard for me to say that, being somebody who actually fixes people and does it every day and knows that I can help these people suffering who need validation for their pain and need to have their pain resolved. And it's really hard being a female inventor, never being funding all of this by myself. Lots of government grants and lots of thesis papers have been published, but I've applied for 2 HEAL initiatives, and it seems like universities get all the money. My PhD from New Jersey Institute of Technology said maybe it's because we're not published together, but I did get published recently in the American US Association for the Study of Pain for pain biosignatures. You can Google that and you'll find my name.
No, thank you for those comments. And you raised a really important point, I think, which is that there are clearly things that people have learned by experience in training and teaching and in clinical practice that have direct applicability. One of the questions, Jocelyn, and you're right, not getting funded for this, but what it means is that we would want, hopefully, someone like you or a younger version of you or other people like you to link up with others who study this in ways that would help us to understand what exactly is it that you're doing. For better, for worse, science likes to have explanations for why things work. And that's not a defense of science. It's a rational approach to these things. So I think I understand what you're saying exactly. And I think it raises the question, and we can add to what we have here, about an exploration of other techniques. And, the issue about physical therapy, the issue about massage, the issue about acupuncture is that it was exactly where you are with regards to the massage therapy and other things now. And, there have been some real progress in trying to understand how it works and who to use it. And that really is my key issue, is who do we use it in, and how do we decide who's going to get better. So I'm going to need to stop there if I might. We're getting to the end of this, but thank you for your comments. I really appreciate what you say. And I've always said that all of my patients leave my office feeling better. Now, I don't do what you do. I use medicines and procedures, and I don't do procedures, but
it helps
do
too.
those, for those who help. But just by talking to somebody who's willing to listen, you can help to make people better. And I'm not saying that's all you do at all. I didn't mean to imply that. But the issue is that we shouldn't give up on trying to treat people and make them better. So let me stop there and say thank you all very, very much. You will be hearing from us shortly about our summaries of all this as NIH puts it together for us. And as we look at what everybody has said, you will be getting an invite either tonight or tomorrow morning to think about times when you could meet. Please be as flexible as possible, and we'll try and set something up in about 3 weeks. And then we will go from there. This will all get discussed again in the executive group that HEAL has put together for coming up with its primary plans for the future. So Claudia, any last words or?
Just a heartfelt thank you to all of our fantastic panel members here and everybody who took the time to come and listen and ask questions and all the things. So we look forward to moving this along. Thank you all.
Yeah. And then Jackie or Whitney or anyone from NIH, anything else? And I'm sorry we weren't able to get Walter on the phone, but
Nope, I think we're good. We can end there, John. Thank you.
okay, great. Thank you all immensely for your time today. And I think it's been a really helpful and fruitful conversation. And I think it's going to make a huge impact on what we've done. And special thanks to Joletta and to David White for their involvement in all of this. And Jocelyn, thank you for taking the time and pushing. We really do appreciate your input, and we will take it to heart in terms of trying to make sure that we can include things like that in what we push for future research. So, and then thank you to anybody who's still on the phone. It looks like most people have left, but we do appreciate everybody's input. Thank you, and see you soon. Bye-bye.
Happy Thanksgiving, all.
Yes, absolutely. Forgot that.